how's your projects going?
Ma'am, we are working on that, ma'am.
I think most of them have changed it, right, Devi? कुछ ना कुछ change हुआ है.
Yes,
So
sir.
everybody changed something after the lectures. That is for
Yes.
sure, ma'am. Everybody something has been changed.
Yes,
Hello,
वो तो
ma'am.
होता ही है. Hi,
Hello,
hi,
ma'am.
Sonali. Hello.
Hi.
Good evening.
Mm.
Avinash sir comes on time. That is what I think. 5:45.
Hi, Meda.
Good evening, everyone.
Good evening, ma'am.
Good evening.
ma'am.
Good evening, everyone.
So, Meda, how's your project going? Meda, you can hear?
Yeah. Hello, Sai. How are you?
Hi. How's your project going?
It has been submitted, but no remarks as such received
Okay,
from the
okay.
mentors.
So, it is on mini CEX, no?
Even I am looking forward to, what changes I have to do or in
Okay.
which direction I can,
Uh-huh.
progress. It is regarding that mini clinical
Mini
evaluation.
clinical evaluation, yeah.
So I was planning to start working upon that sensitization lecture
Uh-huh.
for the faculty and
Hmm.
PG students who will be participating.
Uh-huh.
I just briefly introduced to my staff
Hmm.
on Saturday because we've submitted the project on Friday. No? So I just gave them a brief idea what I'll be doing on Saturday,
Uh-huh.
this Saturday, last Saturday. So
Hmm.
let us see now if we get a green signal from the mentors, I can go ahead.
Yeah, yeah. Good evening, Super sir. Good evening. Hello, sir. Good evening.
Can you hear me now?
Yes,
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 Good
sir.
evening,
Yes.
sir.
Great. Good evening to all of you.
Good evening, sir.
Good evening, sir.
So when do we start? Tell me.
Good evening, sir.
Yeah. So, sir, Nagda madam is joining. Another 5 minutes. We'll wait for everyone to join and we'll start.
Take care.
Professor, based on your lecture only, I chose this topic of mini clinical examination. So I'm
Oh my
thankful to you.
Good. I
Good
leak
evening,
something in
ma'am.
5 minutes by the time you start actually.
Yes, sir. Yes, sir. Good evening, Neeta ma'am.
Good evening, Dr. Sai. Good evening, everyone.
Good evening, ma'am. Good evening, ma'am.
Good evening, ma'am.
देवी प्रसाद सर आपका वो साइनस लिफ्ट का वाज वंडरफुल
Yeah, even I
एग
like
वाला
simulation in dentistry.
सिमुलेशन वाला.
Good
It was
evening,
really
everyone.
nice.
Ma'am,
Hello Shabina.
thank you, ma'am. Thank you for that.
Yeah,
And you know, he explains in a very nice way. No? So that's
yes, yes.
he has got a
I
characteristic.
never thought मुझे लगा अंडा फूट ही जाएगा, but then वो फूटा नहीं. I was so amazed.
No, actually, first I tried without emptying it, but that is not possible. That is difficult, ma'am. But then after emptying it, it'll work out. But we have to be very careful. It'll get If it gets perforated, then it'll get torn off the inner layer.
Same
So
as that
otherwise
Schneiderian membrane, na?
Yes, ma'am.
एकदम
It is
same
just
experience आता है.
yeah, simulation of that.
Actually, I just add up since
I
we are
used to
there.
get it done.
Devi, I'll
Yeah,
add up.
Rupinder.
Okay. Yeah.
Yes.
I was doing a direct sinus lift, the same thing what you said now. So I was still remembering we also started with egg only, but that egg, that membrane is very different from Schneiderian. You know, when you really do it with the sinus lift instrument, वो बहुत ही different होता है. It's very different, ma'am. But yes, actually, everybody starts with egg only.
कुछ तो मन में आता है ना फिर, नहीं तो otherwise it is एकदम left to imagination.
Then second I did was on goat jaw. Yes, ma'am. Where we did direct on goat jaw, ma'am. Where we did using piezo surgery satellite. So I have a piezo surgery unit here also. So there also we simulated, but yeah, the membrane of those Schneiderian membrane of goat are very thick, ma'am. So really, it is very different when you do on patient. So I was doing immediate implant with sinus lift simultaneously. So there I felt every patient is different, really different.
Yes, yes. Every patient is different.
Nice, Devi. Very nice explanation for students. I shared it already. I've shared. YouTube पे डाल दे.
हाँ.
Okay.
You will become YouTube silver button ही मिल जाएगा.
वो क्या होता है silver button, ma'am?
YouTube में when you hit a certain number of subscribers, I think 1 million or so.
1 million.
YouTube, I think so, if I'm not wrong. Then you get that silver button, which they send you by post, and you can monetize your channel and you get paid handsomely.
Dentistry में 1 million subscriber इतने तो dentist होंगे मैडम.
No, it is not subscription. It's viewers, no.
No,
Subscription may be
subscribers.
less.
Subscribers.
1,000 or something.
नहीं.
1 million subscribers.
1,000 to minimal requirement for any monetization.
Okay.
But if you want that silver play button, it is supposed to be very prestigious. Silver play button. तो उसमें बहुत ज्यादा पैसे मिलते हैं. 1,000 रहे तो you get a small amount, like not much. But if you have so many, then you get nicely paid.
Ma'am, I have more than 20,000 viewers, but 400 subscribers, but I'm not paid because you need to have that hours. The main thing is
4,000 watch hours.
4,000 hours. Yes, that is the main criteria for
in 1 year. In 1 year.
In 1 year.
Yeah.
So that is the thing behind that. Rest we have 1 million.
1,000 subscribers plus 4,000 watch hours.
4,000. Yes, work hours.
What are you talking, Sai?
Good evening, ma'am. Good evening.
Good evening, ma'am.
And good evening.
We are waiting for the participants to join for another 5 minutes.
Madam, good evening.
Yes.
Good evening, ma'am.
So I was talking about YouTube channel, ma'am. If you have your own YouTube channel, so you can monetize your channel and earn money through it.
But what did she say? Hours or something?
Watch hours लगते हैं, ma'am.
Watch hours, ma'am.
Hours.
Hours, working hours or watch hours.
So you need 4,000 watch hours in 1 year to be able to monetize your channel and 1,000 subscribers.
So how do they pay you?
They pay you, ma'am, depending upon the number of subscribers. Now, if they increase number of subscribers, so they have different policies.
Policy, yes.
So basic is this 1,000 and 4,000. Then if you have many, then your revenue increases depending on the ads that you select.
Acha, you can select the ads.
Yeah, not the frequency of ad. Otherwise, too many ads will, distract your subscribers. So depending on those 3 factors, you can get paid.
Actually, many of the people don't have ads at all, if you observe, and some people have too many.
हाँ, so ma'am, जो ज़्यादा जिनको पैसे चाहिए तो ज़्यादा ad देते हैं.
Okay. And there are some policies for even Instagram influencers and YouTubers wherein they pay you, they can hike your viewers, which happened with that singer Badshah also. He got paid and taken many years. So it was a scene that time. But then there are people who work for hiking your viewers number.
Right.
They are ethical, like ethical hackers and unethical things, both.
How many followers you have, Aarti ma'am?
I have 400 subscribers, Meda ma'am, and more than 20,000 viewers in a year. So it is a purely academic channel, nothing to work about. But then we received good response, very good response and the highest viewed video was our zinc oxide eugenol manipulation, first year BDS preclinical. So the best part is I receive feedback like students always view that because it's just a short video, which is none of the video is not more, is not more than 3.5 you can say minutes, and there is no background voice. I'm not prompting anything. There's just a music because I know students won't wait to hear. They will just swipe on to see the end part like we do in recipes. इसके बाद क्या?
Hebar's kitchen के जैसा.
हाँ, Hebar's kitchen, right?
I have 1,000 subscribers and some 60,000 views, but not watch hours. Some 3,000 watch hours I have. Still 1,000.
So you're close by.
Have some app also, na?
Yeah. So Nagda madam, should we start or should we wait?
Sir has come.
Yes,
Yes.
ma'am. Sir is waiting.
Yeah. There are 27, 28 now. So
Yeah.
I think, and 3 of us, only 25. Just give 2-3 minutes.
Okay.
Okay, ma'am.
Yeah.
Are you traveling,
all-
madam?
Now for you, sir, how can I miss you? I just found for some work.
Okay.
Yeah.
No. Are you all doing well? I can see a lot of activity on your WhatsApp and mails. I think that is something which is amazing. And I can see your enthusiasm very well. So it's good to see. You're coping very well. That's one of the, I mean, all these courses are quite taking time on you actually.
Yes, sir.
They are in the process of finalizing projects now, sir.
Yeah, I see that activity. So I feel, it takes little toll, but in long run, it is useful actually.
Saiva, may I know your channel or the link?
Yeah, I'll share in the chat box.
Yes, ma'am. Yeah. So it's upon the academics?
Yes, pure academics, prosthodontics simplified.
Okay.
The channel has a video on how to make money on YouTube.
It is worth watching, sir.
Then you'll reach 20,000 hours of.
I think Sai, why don't you are with your so much of knowledge, why don't you make one video? I'm sure you will cross that 4,000 watch.
I will do it, sir. I will do it. Out of fun, I will try. I will surely give a try, sir.
Yes, and you must acknowledge the idea also.
Yes, sir.
Yes, definitely.
No
This
problem.
platform gave
I'm just
so
joking
many
actually.
No, so this platform gave, it
No.
widened our
See,
horizon.
one of the thing, my granddaughter, she's about say 9 years old, but she goes on seeing these videos of these Malaysian two girls and Ayu and Pihu and all. I don't know if you have kids of that age, they would see that. And if you really see, they have some 43 million viewers and something. And the amount of money they must be paid must be huge, really.
Yeah.
So I realize this is a area where there is a lot of work is need to be did. Many of us really get into academics and we try to say that we want to spread the educational strategies. But some of the families, this is a income. And they have income strategies. If you see that Malaysian family, the 43 million views, imagine that.
Yes.
And I think a girl which is say 8 years or 10 years are glued to these kind of videos and all
Casey
that.
and Rachel, kya?
Yes.
Casey and Rachel.
Casey and Rachel and Indian version of Ayu and Pihu. I'm sure.
Ayu and Pihu. Oh my God, sir. Matlab, they are earning like anything.
Yes,
by
exactly.
making some really simple and such
and
videos.
these are videos. I'm sure all of you can really make it with such a simple, not much of big script and all. See, I remember in somewhere in 97, I had attended one workshop, 4 days workshop in AIMS Delhi on how to make videos for educational purposes. And it was a very interesting kind of an workshop, how to write a script, how to write email and all that. But I think we did not really pursue it so much, except for our educational or conference videos. But I think some of these arts, if you earn, I'm sure they could be earning for many actually. Anyway, that's a different thing. Madam, let us know when we can start.
So, thank you, Dr. Supe, for joining. And sir, if you start a YouTube channel, I think you will earn a lot of money. But that is not your aim. Yeah.
No problem.
So we have Dr. Supe. You all know him, and by now you know he's a pioneer in education, medical and health profession education in India. Over to you, sir. I won't take much time. You can start. Yeah.
Sure. I think along with me is, I know Sai is there, and we both of us are going to take you to the journey of clinical reasoning skills. So I hand over it to Sai and we will be changing our roles, and Sai will be taking over now first part. Okay?
Yes.
Yes, sir. Thank you, madam. Thank you, sir. And good evening again to all the participants. So here we are today to discuss this topic of clinical reasoning skills. and various implications in dental education. So we'll start with an exercise first. Let us freshen up our minds, and I want you to write your answer in the chat box. This is a puzzle, and the question is, who will shout first? As you can see, the instructions are on the screen. So I think the instructions are quite clear. We are having 4 criminals, and the judge has asked those criminals to solve a puzzle. And they are all 4 of them lined up in this fashion, shown in the picture. A wall separates the 4th person from the other 3. Criminal 1 can see 2 and 3. Criminal 2 can see 3. Criminal 3 and 4 can't see anyone else. Now, these criminals are wearing hats, and they are told that there are 2 white hats and 2 black hats. They can't see their own hat color, and they are told to shout their hat color as soon as they get to know for certain what color it is. They are not allowed to turn around or move. They are not allowed to talk to each other, and they are also not allowed to take off their hat. So in this scenario, I hope it is clear, what or who will shout first is the question, for which please put your answers in the chat box. So we'll give 2 minutes for this. We have one first response. Very good. Yeah, we have a couple of responses. Give it a thought and please reply, all of you. So we have a lot of ones, couple of fours. Prithika is saying 1 and 2. So, all right. Everyone, please put it. So we have last 30 seconds and then we will move on. Please put your answer in the chat box. Okay, Medha is having second thoughts. Okay, right. So I think maximum of you have replied. The question was, who will shout first, right? So we have a lot of variations, 1, 2, and even 3 for that matter. All right. So we'll move ahead to the second slide. Now you have to answer, why do you think that the correct answer is 2 will shout first? This is the correct answer. And now you have to give the reasons why 2 will shout first. Those who have replied 2 in the chat box.
Or you can say openly, one of you can say also, it's okay. I mean,
all right, you can volunteer and answer. Those who have answered 2 will shout first is the correct answer. So can we discuss and share that why you think that 2 will shout first?
Sai, you want to show them the previous slide?
Yes, sir. Nikita has said 2. Can Nikita, can
Yes, yes, ma'am. So I said 2, ma'am, because he can just see one person ahead of him. So I feel that since that person is wearing black, so the logical reply and the spontaneous reply for him will be white.
Okay, okay. Medha had said 2 earlier. Medha, do you stick to it? Do you want to share? Why do you think?
No, Medha changed her answer to 1.
I second thought was 1. I thought that he can see the 2 hats, and so he'll go for the probability, and he will think that it is.
Shamas said 2. Shamas, are you there?
Yeah, same answer like what Dr. Nikita said. He will see. He will just see the first, the one person, and say he is wearing a black hat. That was my conclusion.
Sure.
Okay, Pritika had said 1 and 2. I think Pritika wants to add something.
Yes,
to this?
yes, ma'am. Why I told 1 and 2 was because both of them can see the persons ahead of them. So that is why they shouted randomly. That is why I had thought so.
Okay, sir, you want to debrief?
Okay, I think, see, if you understand this, is a very simple way of logic through went. Now, see, one can see one black and one white hat. So he doesn't know whether what he's wearing is a white or black. The number 3 doesn't think anything. Number 4 doesn't see anything. So only person number 2 will see a black hat in his front. But he should think that if both the hats were of the same color, 2 and 3, then one person would have easily known that his hat is of different color. The fact that one person has not shouted, second person will shout, and he will say that my color is different than the 3 color, and therefore he will shout that my color is white. You realize the logic behind all this? Hello?
Yes, sir.
Yes, sir.
Yes. So now if you think back, you know, it's very simple to say that the number 2 will shout first because he's the only one who logically thinks he will get a clue. Other 3, 4 have no clue at all. One person is going to have a dilemma. So the only person who can think logically is number 2. So I think that's the way the number 2 is the right answer. Does that make it very clear?
Yes, sir. Absolutely.
Yes, sir.
Sure.
Absolutely.
So let's go ahead, Sai.
Yes, sir. So I think we have already reflected upon this, and so shall we move ahead, sir? Or
no, I think I want to ask them why, how did they really think about this, and what are the process of thinking in their mind? Why they thought of 4 or 3 or 1 or 2? What kind of a process they went? I just want their 1 or 2 kind of thought processes on which they went.
So
one who came right and
2.
one came wrong. One came right and one came wrong. I want both of them to say. So Ashwin,
Niranjan sir has raised the hand. Niranjan Divekar.
Fine. So Niranjan can say and then Ashwin can say.
I feel it's something like a script concordance test.
Okay.
You can have 2 possibilities. There is no one correct answer. There can be 2 correct answers. This is what I feel.
Yes.
Okay. Which 2 correct answers you could think in this case? Niranjan, can you explain me which 2 answers will be in this case?
So 1 and 2. Option 1 and 2.
Why one has no definite answer? No, it's a guess. While 2 has a definite answer.
Yeah, he will be in a dilemma, no doubt about it. But probably he will go on a probability possibility check.
So if you really see, 2 will be able to definitely give an answer. 1 can give by guess. Same way is 2 with 3 and 4.
By chance.
Okay.
By chance.
By chance. Okay. Next slide. Ashwin, you want to say anything?
Yes, almost similar because for number 1, the chances of getting the answer right are 50-50. So 50% chance of the right answer. For number 2, he has already seen 1 black. So the unknowns are 2 white and 1 black. So the chances of getting his answer right, if he says white, is of 60%. So possibility is 66%. So possibility wise, he stands a better chance of statistically getting the answer right.
But one of the most important thing is that one person is not shouting. Yes. That gives us such a big kind of a reasoning behind him, no? So that means I think you have to think one step behind the probability, no? And that's what we normally have to do in a clinical diagnosis, I think so. Anyway, let's go and understand this more actually.
Right, sir. Thank you for that debrief. We will move ahead with the session here. And as all of you can see, I hope you can see the screen. Yeah. So here we are after quite a long journey in dentistry. We have evolved and responded to the challenges of the new generations, and we have employed the technology to a very large extent in our practice of dentistry, especially in prosthodontics. So from these ancient treatment modalities, we have now come to CAD/CAM, digital dentistry, implants, and we have come a long way. So the dentistry which was practiced earlier is no longer the same, and with every passing decade, we seem to make a significant amount of progress. Now, in this context, the decision-making skills become even more relevant, because what we used to practice changes with the changes in technology and newer evidences. So let us see what this is all about. First, we'll begin with the definition. So what is clinical reasoning, or what is clinical reasoning skill? It is an ability to sort through a cluster of features presented by a patient and accurately assign a diagnostic label, with the development of an appropriate treatment strategy as the end goal. It is also the ability to integrate and apply different types of knowledge, to weigh the evidence, critically think about the arguments, and to reflect upon the process used to arrive at the diagnosis. The terminology may vary to include terms such as clinical or medical problem solving or diagnostic reasoning, but the essence remains that it is a complex cognitive process leading to meaningful interpretation of patients' problems and formulation of an effective management plan. So this basic concept of decision clinical reasoning. Now, when we see in terms of in our field of prosthodontics, it is a process by which we determine who needs what and when. So basically, which patient needs what treatment, how we are going to perform it, and when exactly it is indicated. So all these complex, like I said, complex cognitive process goes into decision making process. So all of us will agree that successful prosthodontic rehabilitation involves making many interrelated clinical decisions which have an impact with each other. We have to choose the type of pre-prosthetic treatment. We have to choose the type of prosthesis. We have to also choose the material. We have to choose the duration of, if there is any provisional or temporary treatment, to check certain parameters. And these decisions of at various stages have impact on each other. So all of you will agree with me that success depends on how efficiently we manage these decisions, as our treatment aim is not only to rehabilitate but also to preserve, also to restore the form and rehabilitate the function. So we have a very large amount of responsibility, because our treatment comes at the end. First the endo, then the perio, oral surgery, if orthodontic treatment, and in the end is the rehabilitation. So when we rehabilitate, we not only replace the missing thing, we also preserve what is remaining. And therefore, there is a lot of responsibility on our shoulders and a lot of important decisions to be made, because ultimately it is the prosthodontist who will be facing the patient as to if anything goes wrong, because the patient comes for replacement of teeth, and that is what our job is. Patient will not come for a endodontic treatment or a orthodontic treatment to us. If we want these treatments, we are going to have it as a pre-prosthetic step, but ultimately the replacement work is done by us, and that is why we are the main sole care providers, if you can say so, in this process. So our role in this decision making is very, very important. Now, coming to different decisions that we make, there are certain tasks which are simple and certain tasks which are complex. So it's a simple task wherein the uncertainty is low. You are very sure about the outcome, and these are the very frequent cases that come in our OPD. And there are certain complex tasks where the uncertainty or the outcome cannot be determined or cannot be said for sure, cannot be predicted for sure, and wherein you have such cases are few, but then wherein your decision making has to be very analytical and evidence based, and sir will explain in the subsequent slides. So these simple and complex tasks both we encounter in our practice. And here, like, suppose we are doing a root canal therapy, or we are doing scaling for a patient, we are giving a local anesthesia, or we are just taking a radiograph. Now these are having certain predictable outcome, so we start and we get an outcome which we can predict to a very large extent. But then when such particular therapies, we employ new material to such simple jobs, suppose I'm giving a local anesthesia and I'm employing a newer material, or I'm giving a replacement of a tooth with a newer technology, then those outcomes become uncertain, right? So it is not always that we will have very predictable outcomes in our practice. We have to deal with newer materials, newer technologies, and newer evidences. And also the mindsets of our patients are changing. So patients only demand newer technology, newer materials for their treatment. And that is why we have to be very good at selecting those materials and technology for that particular case, because the uncertainties arise because of introduction of such materials and technology, and also depending upon the patient's biological factors. So when we talk about two patients who can have nearly the same anatomical and biological status, defining treatment solutions that are practically similar, however, it can happen that the other aspects of socio-economical background of the patient, or the time constraints, so we may require two different solutions for even if the anatomical and biological factors are same. So there are other factors also which influence our decisions. So here we are dealing with uncertainties due to materials, due to techniques, due to the socio-economical status, and that is why this whole decision making process becomes complex. So it is important that the implications of seeing all sides of the coin is profound, and especially when the psychological, social, and economic sides of the treatment decisions are considered. And that is why the concept of clinical reasoning is very important. So, sir, we will take now the exercise. You have to reply in the chat box again. Please think about your choice of specialty, profession, and job, and mention what influenced you in that decision making. What are the factors that influenced your decision making about the choice of specialty, your profession, and job? And please comment in the chat box. Yeah, so we have replies coming in. Marks in the examination. It's a realistic one. Technological advances. Foresight in the future. You have to mention what are the factors that influenced your decision making. Suppose I became a prosthodontist, what made me choose that profession?
Say frankly, the marks only were important.
Yes. I appreciate that honest reply. Marks and finances, that is another honest one. Liking for the subject, very good. I was able to do border molding when others were failing at it. So some of you wanted to excel in the subject because they couldn't do it in the UG. So they took the PG seat and mastered the subject. Some were influenced by their guide, because we have a Vaibhav Avinashi sir saying, I became a teacher because of my guide, who was and is one of the best teacher. right? So motivated by a role model. Role modeling is quite, we can see 2-3 answers on role modeling. I was fascinated by a female prosthodontist in my UG college.
Okay. Saik, we can go on to the next slide now actually, because we had got the variety of various causes, no?
Right. So there are various factors we have seen in the earlier exercise, what influenced your decision. Now, I want you to look at the next slide and reply in the chat box. When do you want to visit the beach? So this is option A and option B. So unanimous A, I think. Can't see B as yet. How come it is crowded so much? So many
And
want
alone B.
Alone B, yes. Lalit Kumar is saying B, okay.
See, when he's saying when he's a wife, he wants A. When he's without wife, he wants B. Okay.
Okay. Shall we move ahead?
Yeah, sure.
Yes.
So if you realize actually, I think both the examples gave you that there are a lot of components of a decision, and that influence how you take a decision. And that is very important for you to really understand when we understand clinical reasoning. So let's take what does the decision maker want to achieve when he's making a decision. Now, let me see a patient who is really comes to you, and he is a patient who has some disease. What is his aim? I want to live as long as I can. I want to be able to function the way I function now, and I want to reach quickly. Now, see, every word has some trade-offs. Now, when I say I want to become rich quickly, I may have to give away my ethical background. Or if I want to become rich slowly, then you will have to really continue to work for a longer period of time. And see, conflicting objectives always employ trade-offs. That means you would like to trade off something to get something. Now I want to be like this, then you may have to pay higher if you want to have a beach which is alone of yours, and something like that, or something which you may have to really think about. Can you go to the next slide? So there are always alternatives. So actions that can be taken, not acting is also could be an alternative. For example, treat a man with a pancreatic cancer with surgery, treat with chemotherapy, or leave him untreated. Now, leaving a patient of cancer untreated is also an alternative. Sometimes people can take this decision very consciously that we are not going to take a patient for cancer, or we are not going to treat this patient on ventilator, or we are not going to do any prosthodontic kind of a procedure in that patient. So itself is a component of a decision. So conditions that may or may not be present relevant to the results of decision, not under your control. As I think she very rightly said, biological behavior of any cancer. Now that is not in our control. That is beyond my control. Some patients of having same cancer, one of them may rapidly grow, one of them may not rapidly grow. So that is not under my control. Next. And there's a lot of psychological or subjective value. For example, if one outcome of a radiation therapy is nausea, some people will find that outcome is worse than the other people. So I think if there's always a balance between nausea, pain, and cancer, you see so many people leaving chemotherapy and radiation because they suffer from nausea and hair loss and others. So they are not able to tolerate it, and they leave their chemotherapy halfway. So there is a lot of psychological and subjective value in clinical decision making. Next slide. So what is importance of CDM in managing sick patients? Patients still die from a simple thing, either missed, delayed, or done suboptimally. And approximately 80% of clinical time is spent in cognitive domain. All of us work though we call ourselves as surgeons or prosthodontic surgeons, we still work 80% of our time in cognitive domain. We still continue to make decisions, think and all. And therefore, it is very important to introspect this whole concept and look at it more carefully. So what we are going to do, we are going to take a little deeper into all this. Next slide. So let's go into the simple way of how do we make decisions in modern medicine and dentistry. Now, if you really look, this is a chart. About 5% of decisions, what we call as intuitive or gut feeling. You know, this is called a shotgun approach. I see the patient and I feel this is the diagnosis. You know, I walk in, I say, okay, I feel this particular patient has some cancer, or this is my gut feeling. There are 15% patients where we do algorithmic decisions. That means what? I'll show you that we have algorithms. And most of the time, what we do is a heuristic decision making. That means hypothetical decision making. And this is where the reasoning comes into a big way while taking a decision. And most of our decisions are like that. For example, intuitive, what is called as a 5 seconds rule. There's a 27-year-old man comes with the pain in surgical ward, alcoholic. I come and see on the round and I say, oh, he has acute pancreatitis. Then I get diagnosis. So this is quick recognition. Next slide. And if you really see, a general practitioner's cancer related gut feeling is something which has been one of the well-documented kind of an gut feeling or intuition is one of the way of making diagnosis. Next slide. Algorithms are very commonly used that you have a particular chart that does patient have, say, a particularly thyroid swelling. Now, is it solid or cystic? Then you say it's a cystic swelling. Then you say whether it's a clear fluid or it's a blood. Then what is the kind of cytology? So you have a particular way of pathway based on your clinical as well as your, does it move with respiration? Does it move with degglutination? You know, all these kind of actions you ask. And then you come to a diagnosis that, yes, this is what it is. Now, this is algorithmic way. Same way, if you find there are algorithms in the prosthodontics, that you can go with the various kinds of tooth and a traumatic tooth extraction, and then you can really go on how would you really go into these kind of pathways, and that's where you can reach and you come. This is about 15% of where you make diagnosis. Next slide. But heuristic decision making is something which we learn by a clear power of watching. So what do we do? There are two aspects of judgment. One is observable and other is unobservable. Observable is where you predict unobservable state and duration of fever. We ask a question, color of the phlegm or white blood cell count. And then we say, okay, whether the patient has virus or infection. You know, I think many times coronavirus, though RT-PCR is one, there are many people we could make a diagnosis that this is bacterial, this is because of the virus, you know, something like there's a component of a decision making which happens. Next slide. So most important is how well we use cues. All of us see patients, but you know, when I was a student, I used to always get impressed with my boss, how he picks up things. So none of the cues may be very good, but the judge may still get most he can out of them. And in other extreme, there may be a perfect cue, but the judge does not use it. We have seen this often in various stories and how we can really use it into the clinical practice. So next slide. I'm going to show you this video. Can you run this video?
Yes, sir. Yes, sir. Please let me know if you can, if it is audible. Huh? If it is not, I'll play it directly.
It's not audible actually. You have to share that sound when you do that.
Okay, I'll play it directly. Just give me a moment.
You want me to play it?
No, sir. I'm playing. Just give me a moment. Can you see?
Yes.
Joseph Bell was an extraordinary teacher by all accounts. And Conan Doyle, writing about Bell, described the following exchange between Bell and his students. So picture Bell sitting in the outpatient department, students all around him, patients signing up in the emergency room and being registered and being brought in. And a woman comes in with a child, and Conan Doyle describes the following exchange. The woman says, "Good morning." Bell says, "What sort of crossing did you have on the ferry from Burnt Island?" She says, "It was good." And he says, "What did you do with the other child?" She says, "I left him with my sister at Leith." And he says, "And did you take the shortcut down Inverleith Row to get here to the infirmary?" She says, "I did." And he says, "Would you still be working at the linoleum factory?" And she says, "I am." And Bell then goes on to explain to the students. He says, "You see, when she said good morning, I picked up her Fife accent, and the nearest ferry crossing from Fife is from Burnt Island, and so she must have taken the ferry over. You notice that the coat she's carrying is too small for the child who is with her, and therefore she started out the journey with 2 children, but dropped one off along the way. You notice the clay on the soles of her feet. Such red clay is not found within 100 miles of Edinburgh, except in the botanical gardens, and therefore she took a shortcut down Inverleith Row to arrive here. And finally, she has a dermatitis on the fingers of her right hand, a dermatitis that is unique to the linoleum factory workers in Burnt Island." And when Bell actually strips the patient and begins to examine
Okay, can you go back to the presentation? If you see how beautifully he has analyzed just based on looking at a patient. And with 2 minutes of his interaction, he has picked up so many cues. And I think we also, when a patient walks in our OPD, we should start watching not only the patient, but how he speaks. What is, sometimes that is the way we really go. Of course, sometimes we can get lost, but most of the time, if you start creating or preparing your vision for this, and that's where the heuristic is easier something comes to mind, most likely it is. When are you hearing barking? Don't think of zebras. Of course, many times you have some biases, which we'll talk about it. Sometimes people go to their recent personal experience or conference, and they start diagnosing more of those cases. Now, if something like that happens, you have to really think about how we are going to work on this. And this is our day-to-day practice. We work like that. So we have to really understand this process. So uncommon presentations of common diseases are more likely the classical presentations of rare diseases. You understand my point? So you will find uncommon presentations of a common diseases are more likely. And next slide. And if you really go, so there are theories about heuristics, which I'm really going to take you to these theories. Now, there is something called as a classical decision-making theory, and it's called as a Bayesian probability theory. And second is a multi-attribute utility theory. Now, I'll explain you, which is simple actually. Now, next slide. What you really have to understand is that you have a particular kind of an patient, and he has particular findings. You identify exhaustive set of mutually exclusive hypotheses. That means this particular patient could have this, A, B, C, D, E. And then you go on assessing the probability like we went for the first example. Why 1, why not 2, why not 3, why not 4? And then identify all the potential observations that might bear on each of these hypotheses in future, and then quantify the impact of each an observation which might have caused this. So this is where the probability starts working. As somebody was rightly calculating, this patient has a 50%, number 2 has 66%, something like that is a process of this Bayesian probability theory. Next slide. Now, based on that, you have specific set of possible actions that this patient, as I said, could have 4 or 5 different kinds of therapies. You could easily say that, okay, this patient socioeconomically doesn't look good, so I cannot really give him the best possible, the newer kind of a model. So I'm going to get to him. Or this is not going to fit into this. He is a particular kind of a non-veg eater or something. I don't know. You may have your own ways of really thinking. But you try to look at solutions. You look and score each action with every evaluatable dimension and calculate to that score to find out what is desirability. And this is the way by which we think. And this is the way we come back to the utility of that theory. So these two theories form the basis of heuristic decision making and the way we treat patients. Next slide. You can read about this. There are books and books on this. And somebody might say it may take a lot of time to do all this. Yes, in the initial phases, when you are a first year, second year, it might take time. But as you grow, next slide, there is something called as a process of reasoning. You know, Q acquisitions, hypothesis generation, Q integration, and hypothesis evaluation. All these processes happen in our mind like a hard drive which rotates very fast. And what we call as a mental shortcuts, cognitive shortcuts, they happen in a mind, you know, but sometimes it fixes in your mind also. Next slide. So something called as a cognitive or mental shortcuts occur. So that becomes your natural decision-making setup. And high stakes, time pressure, inadequate information, and unclear goals. You know, sometimes you find you, depending upon the pressures and everything, I'm sure in an OPD, when I'm seeing, say, 200 patients, sometimes these mental shortcuts help me to take decisions very quickly. And everybody, over a period of time, as you start becoming senior, you start getting this cognitive or mental shortcuts. And this is the basis on which we go through both the processes of theory very quickly. Next slide. So let's go and ask a simple question I'm going to ask you is, what are challenges and issues of reasoning process? Now, if you have understood this, the way we reason out, what could be the challenges? Can you put it in a chat box just to let me know what could be the various processes you think about? Resources, very one thing, but this is a cognitive kind of a process, right? Why do you need more resources for this? Biases, very nice. Systematic observation, knowledge and experience, environment, ego, very rightly said. You know, sometimes we have too much of ego. My diagnosis cannot be wrong. Time, previous experience, very nice. I think past experiences. Less information, you have inadequate information, and you have not adequately investigated a patient, and that could make you go wrong. Yes. I think very rightly said. Can we go to the next slide? Prejudices, that is biases. So what we are, I know there are so many reasons, but we are going to really discuss these two aspects. One is the biases and errors. Okay. Now, everyone makes a mistake. Our reliance is on cognitive processes prone to bias mix and treatment errors more likely than we think. You know, so the bias comes into picture in all these cases. So next slide. So Sai, you want to take this?
Yes, sir. Right. So the first type of bias we are discussing here, out of many biases that have been reported in the literature, is a confirmation bias, where the clinician tends to find the data to support an existing hypothesis rather than considering the alternative. So he has made up the mind and he's trying to find out the data from the investigations or from the clinical examination that will support that particular diagnosis, which is already, you know, or a hypothesis which he has already thought about. And if the conflicting information comes, then he is most likely to ignore it. So this is a confirmation bias. And the next example that we can see here is, suppose for in our clinic we have a 60-year-old female that has come and she is edentulous, and she's come with angular cheilitis, and the dentist suspects vitamin B12 deficiency and orders lab tests which show that there are lower levels of vitamin B12. So the diagnosis of B12 deficiency is confirmed, and we give the supplements and discharge the patient. But then we fail to consider that loss of VD due to worn out denture, you know, which she's already wearing, can be the one of the reasons why she's suffering from angular cheilitis. So this is an example of a confirmation bias. The second bias we are discussing here is an anchoring bias or premature closure, wherein we can see this example. 33-year-old male with multiple visits for myofascial pain dysfunction syndrome has presented in the clinic with acute pain in the right temporomandibular joint. Now, the resident states that this patient is always here. and just wants medications. He's a frequent visitor. He has bouts of MPDS every month, or he's just this is another visit that he has paid to the clinic, and he diagnosed as this case as an acute exacerbation of chronic temporomandibular disorder, and he has given the stabilization splint. Now here there is a failure to consider disc dislocation or subluxation, and we have to be very careful about asking the history, because even if the patient is having MPDS, which is a chronic MPDS, this time he may have received some trauma, or there may be some clinical incident where he may have dislocated the disc, and or the disc has undergone subluxation. So anchoring bias or premature closure. The other bias or other phenomena we are going to discuss is I am the super boss kind of a thing, wherein first year resident reports missing healing cap of a patient one day after full arch implant surgery at the time of provisionalization. So we have placed full arch implants. Next day the patient has reported for provisionalization, and this first year resident says one of the healing cap is missing that I had placed yesterday. The supervising faculty orders chest and abdominal X-ray to locate the same, because it is a very important issue. Patient should not have swallowed it, and it should not go into the chest. So the resident, actually what has happened is the resident has failed to notice the displaced healing cap under the sutured flap, and here the failure to consider lack of clinical experience of that resident. The supervising faculty could have considered that this is a novice trainee, and could have misplaced the healing cap under the flap, which is a fresh wound, and yesterday only we have placed an implant. So the wound is fresh, it is not approximated yet, and it is very likely that the cap has undergone or missed inside the sutures. So this is a very important finding, and this is a real case which had happened in our college, and that is why I thought of sharing it with you. So this is another one is availability heuristic, overestimating the probability of a disease in a patient via the recollection of a previous patient with a similar presentation. Again, such cases often happen with temporomandibular disorders and orofacial pain. So another factor is fixed ideas, wherein if we can't find an organic cause, then we label the patient as psychosomatic. Very, very common in orofacial pain, TMDs, wherein we fail to locate an occlusal interference or something which has triggered it, and then we label it as psychosomatic or induced by stress and anxiety and other factors, and try to counsel the patient and send the patient back without any active treatment. So fixed ideas, fixed notions. The other example which is very interesting is I must do something kind of a thing. So an 86-year-old patient with systemic comorbidities presents with a worn out dentition with single missing molar. He is able to eat and function properly. Examination reveals generalized grade 2 tooth wear, and we decide to go for a full mouth rehabilitation rather than replacement of that single missing tooth with a night guard. Now here what is happening is we are failing to not treat where minimal treatment is required. Okay, and this treatment of full mouth rehabilitation in an 86-year-old geriatric patient with comorbidities may be potentially harmful. So here, like sir has said initially, that sometimes doing nothing is also a wise thing to do. So over treatment without getting considerations to other factors is also very damaging. Now another example is previous errors. They say we have a resident who has recently missed a diagnosis of peri-implantitis on IOPA. Okay, and as a result what happened was the implant was lost. He could not diagnose it at appropriate time, and as a result the implant was lost. The next day the same resident reads the crestal bone loss in implant placed in fresh extraction socket as early signs of failing implant. Now all of you will agree that if we place implant in a fresh extraction socket, crestal bone loss is inevitable to a certain extent. But since the resident is now under that concept of misdiagnosis, he is being extra careful, and he again has incorporated this emotional bias from previous error, and again there is a diagnostic error that is happening. So effect of previous error. And one more very interesting thing is gambler's fallacy. Sir, you would like to tell about this gambler's fallacy?
No. Sometimes, we look at the thing like we average 5 cases of myocardial infarction per weekend. It is Sunday night, and so far we have only seen one. So the next patient of chest pain is likely to have MI. We are due. Some of these are, it looks funny, but that's the way sometimes you try to make a diagnosis, and we get fixed in our ideas. Okay, this is what it could be. So we have a lot of biases in our mind, which we carry while making clinical reasoning. And we have to be really rational to take away these biases. And this is where a unit discussion and confirmation really makes a lot of difference. And I always feel there's a difference between people in medical colleges or dental colleges versus practitioners. In medical colleges or dental colleges, there are a lot of people to correct your biases. And a practitioner always is a boss. So he goes into a super boss because nobody questions him. While a medical or dental college, there'll be 100 people will question him. And I think it's important the way we learn and we take decisions. And this is where I think we should go away from these fallacies. And if you really go through the next error, which was the diagnostic error. Now, diagnostic test, the decision-making viewpoint, I think assume there is a possibility that a patient has a disease and we have a treatment which is effective if they are sick and dangerous if they are healthy and undesirable. For example, tuberculosis treatment. You are giving an AKT to a patient who has sick tuberculosis, and you are giving an AKT to patient, a normal patient. It has its own side effects which are likely to happen. So you have to understand that there are various kinds of decision analysis. You are treating a sick, you are treating a healthy patient, you are ignoring sick because you have not diagnosed him, and you are ignoring healthy even if he's sick. So we have 4 different conditions which are there. Can you go to the next slide? What happened? You went out of presentation.
Yeah. I'm getting back at it.
No problem. So just go into the next slide. Okay. So now if you look at this slide, there are some patients who are healthy and who are treated as healthy. That's where the investigations come negative and diagnosis is okay. There are some patients who are sick and they are treated as sick. For example, there are tuberculosis patients and you treat them as sick. That's also right. But if there's a healthy patient and you treat him as a sick, like on a diagnosis which is not very clear and patients are given empirical AKT and all that, it becomes an alpha error because he's a healthy patient, but you are still treating him as sick. And if he's a sick and is treated as healthy, where you are not able to diagnose, that becomes a beta error. So what you have to worry about is that I should minimize my beta errors. And if the treatment is very difficult and risky, then the alpha errors also need to be reduced. So the whole concept is that during this clinical reasoning, we should try to minimize our beta errors first and alpha errors at secondary. And let's see the example. Next, go to the example. Let's look at a test which is common and uncommon. Now, a disease is common and disease is uncommon. And look at the sensitivity of 90% and specificity 90%, which is a very high sensitivity. Now, even if you have done this 90% specificity, there are 10 patients where you make an beta error and 10 patients will make an alpha error. Now, if the treatment is very simple, something like if I'm going to give painkiller, then it doesn't matter because the risk of allergy is very low. But if I'm going to give this patient risky injections or risky surgeries, risky treatment, then it is going to matter to me that I'm causing harm to the patient. In fact, if the disease is uncommon, then you know the difference. 5 patients will have alpha error while 195 will have a beta error. That means there will be many patients who are sick will be missed. And this is what worry all of us have to really do. And therefore, when we are doing this analysis, we should all the time be conscious that am I making beta error or alpha error? But in a clinical practice, sometimes we continue to treat and we forget that we may have biases, we may have errors. And if you are aware of this, then you will be more careful, more conscious, and you would look at the things more prospectively. And that is what exactly we need to really think in a clinical practice. Next slide. So the goal of a diagnostic test is to move the probability belief higher or lower, ideally enough to cross a threshold. So when you're doing a test, whether it's a CT scan, whether it's a WBC count, or whether you're doing any blood test, for example, a better test is one that leads a greater belief of revision. That means my clinical diagnosis has so many cases, and my diagnostic test, I'm able to improve my errors or diagnostic ability. I'm doing that is a better test. And if management will also be the same, no matter the test results, don't bother about the test. This is very important. And this is what exactly happened in a mild Omicron. People were so worried about COVID in the first wave and second wave. When the Omicron came, people just say that the test is not going to make a difference to me if it's a mild. But of course, there are some elderly patients which were not monitored, we still lost. But people's belief is that, and clinicians' belief was that the management is only going to take paracetamol and rest. Then why should I really do it? So there are different implications of this in our day-to-day life. Next slide. So let's go and ask Sai, would you like to take this exercise?
Yes, sir. I would request Samik. Are you there? We need the breakout rooms.
So, I mean, we are going to ask you this question.
madam. Breakout room karje 8 minute mate and automatic.
Just let us give her 1 minute to explain, madam, this. What we are going to do. How do we teach clinical reasoning to our students? What we are going to do is, how do we teach clinical reasoning? So we are going to break you out in, take you into breakout rooms. And we would like you to discuss 8 minutes in that group. That now that we have understood the concept of reasoning, how are you going to make your students learn it? And one participant will be discussant, one will present it to you in plenary for 2 minutes. I think because of the shortage of time, we are going to restrict your presentation to 2 or 3 groups. But I think we can go into the breakout rooms now.
Yeah, Samik, can you activate the rooms? Yeah. Participants, please join your respective groups.
All of you can automatically join your groups.
Yes, ma'am. Only 3 are left. The rest have joined.
Shamas. Rajiv. Shamas. Samik એને મૂકી દે ત્યાં.
હા મેડમ એમનો ગ્રુપ જ ગોતું છું.
મૂકી દે મૂકી દે.
હા હા. મસ્ત ગ્રુપમાં છે.
So, ma'am, Verma sir is taking a session, is it?
Yeah, he's taking one. Remember, he had spoken once on artificial intelligence.
Artificial intelligence.
So I asked him, I gave him something different, but he said, let it be this. I said, okay. I told him long time back to do on interprofession education because that somehow I wanted to cover a little overview. Doesn't matter, I'll do it later.
So 7:30, no, ma'am?
1 hour only. Supe sir has logged out or what?
Yeah, I can't see him. I'll call him.
Or maybe he's, I don't know.
He's in room 4, ma'am.
Yeah. Okay.
Hello. Hello, Sai, can you hear me?
Yes, sir. Yes, sir.
So you did not go to any breakout room?
I went and came back.
Okay. So they will come by anyway in 1 minute, they'll come back, no? Okay. They will not come automatically.
They will, sir. Just a few seconds left.
This meeting is being recorded.
Okay. Is everybody back?
Yes, sir. Yes, sir.
Now, which group wants to? We will take about 3 groups just because of the shortage of time, but we would like to know one group which you would like to begin. Group 1, 2, 3, 4, 5. I think somebody has already raised the hand. So, Niranjan, can you
Yes,
really
ma'am.
speak for your group? In about
Yes,
2
sir. Yes,
minutes,
sir.
you can tell us what are the ways by which you feel you should teach in clinical reasoning.
Yes, we have to encourage the students why. I mean, they have to question
Very good.
why
I
for
think that's
every step.
yeah.
Improvise the metacognition part of it with a logic model, just like we have to think like Vulcans in a Star Trek, only by logic.
Yes, true.
And say we can make use of the techniques called think aloud or talk through or thematic analysis or any pattern recognition is there, like just like an example which you gave, black and white hat, or
Yeah.
it's based on a case-based learning. I mean, you create a clinical vignette or a scenario, and then encourage students to generate a clinical pathway in through algorithm or a flow chart, and encourage critical thinking process through reflection. This is what I
Sure.
want to conclude.
Sure. See, there are two components to the whole discussion. One is what aspects of cognitive thinking you want to promote. And secondly, what are the various methods you will use into your clinical teaching? You understand my point? So, as he rightly said, we want to really encourage metacognition, logic, think aloud, and all through building cases in that particular way. We have to make a lot of thinking that how I'm going to build a case and which point I want to bring about. Like somebody said, I want to bring about socio-economic aspect. Then you have to build in that component into that discussion of that case, or you have to pick up that point at that particular point of round. And then I say, today I'm going to talk on students, make them realize that you're going to talk about how socio-economic status influences your clinical decision. Maybe this is a built up a teacher does over a period of time to make students realize all aspects of clinical teaching. Another group, can we go to the other group? Thank you, Niranjan.
Rekha Gupta, madam.
Thank you, sir.
Thank you, Niranjan.
Sir, as you rightly said, one thing we need our students to understand is what are the different options available. There could be multiple treatment option available for a given clinical situation. So the student has to learn to analyze what are the different options and which one to be chosen out of those. So which one to be chosen will be decided upon what was the patient's chief complaint, and what was his expectations, with what expectation he has come to us, and what are his limitation. Patient's limitation in terms of one aspect we said socio-economic status. One could be time factor also. So we want to go for conservative one or more invasive one. Then his health status also is there. And whatever the different treatment options are there, what are the pros and cons of each?
Okay. Now, how will you build up into your clinical teaching? The whole exercise is that all these factors are important. How will you build them into your clinical teaching?
Sir,
how will you make your students realize? Let me tell you, Rekha, you have a child. You have a child,
sir.
or yes. So how do you teach a child of 6 years to respect something like that this can break? How will you teach him?
So there are two ways. One is to learn from the mistake of the child himself. If something was breakable, so one thing is I try to keep it out of the reach, and I warn the child that this is breakable and you have to be cautious while handling this thing. Second thing is, if some mistake has already been made, then learn from that mistake. See, this was done and it could have been prevented if we have done it in a different way. So I think
either you use the existing experiences and build upon him,
yes,
or you create experiences or some kind of situations through which you build kind of a reasoning to them. Yes, so these are the two things which all of us should really understand. I'm sure there are many ways of doing. So and the third thing is what he says, how do you teach people mental shortcuts and all? It is many times a practice. I think let's take to the third group, Medha.
Sir, much has been said. I will just add one thing, that the most commonly encountered clinical situations should be treated, should be taught in an algorithmic fashion, that such and such patient reports. So what next, and what next? And secondly, what I feel Dr. Niranjan said, reflection is also very important if we are going to if we have to develop this clinical reasoning, like the student has to go back and reflect on why he chose this particular as a treatment option for the patient.
Fine. I think there are two components to two answers to what you really said. The second thing you said is absolutely right. You have to make people reflect.
Yeah.
And while reflecting, make them aware. Something like what we did, that we asked them to shout, why did people talk about two? And then we went on back and asked you to reflect. And then we made you narrative also. So that really helps us to make you aware. How did you really think about that? The first
And
point
I think,
you said.
sorry.
Please speak.
So I think when a teacher teaches in this particular manner, that is more better absorbed than what just the classroom teaching, the routine classroom teaching. That is what
Absolutely. The first aspect you said about using algorithms is not very true in every case. Because if there are not many uncertainties, then algorithms work very well. But if there are a lot of uncertainties, then algorithms don't work well. And untoward effects. Sometimes, most of our decisions in clinical are not predictable. So in that case, algorithms don't work. Algorithms work only in 15% cases when you are surely certain about the diagnosis. Okay, so there you use algorithms. But if you want to make people realize clinical reasoning, you have to use these different methods, like you said. Somebody said improving their mental shortcuts, kind of creating cases with particular kind of thing, and then also trying to use reflections. All these methods will tell you how do we take about. Can we go to the next slide now? Okay, so Sai, you want to really elaborate this more?
Yes, sir. So, since we have reflected upon the various strategies, let us see what all we can, employ for teaching the clinical reasoning skills. So, strategies are listed on the left and the purpose on the right. So, first is to provide exposure to a rich volume and variety of clinical conditions. This way, what happens is students learn the prototypes of different diseases. They are able to compare different contexts, and this facilitates quick pattern recognition. So exposing them to the rich volume and variety of clinical condition is the most important strategy. The next is to give them enough time to prepare each case. So this will allow the students to gather the data, process information, and reflect upon it. And it also activates the prior knowledge. The other strategy we can employ is to encourage the students to state possible diagnostic hypotheses early in case presentations, very early. For example, what do you think this patient is suffering from? This commitment, this early commitment to a possible diagnosis encourages development of reasoning approaches. So during a case discussion, also what we can do is we can link the clinical knowledge to basic science concepts. So this way we can activate their prior knowledge and allow the students to contextualize basic science concept. So linking with the existing knowledge and encouraging them to commit early in the diagnostic process to develop the reasoning approaches. Also, we can emphasize forceful features. It also helps to build the context specificity. So very, hallmark features which are there for a particular case, we can emphasize and to build the context specificity. We can ask students to prioritize differential diagnosis periodically with addition of each new bit of information from history, physical finding, investigation. So this will help them to proceed in a logical manner and also teaches them to change the diagnostic probability using additional epidemiological and clinical data. Okay, so prioritizing various differential diagnoses. So there can be n number of diagnoses possible, but then prioritizing them and then revising that as and when the new information keeps adding on. So this is how we can develop their logical, sequencing, logical reasoning. Also, we can ask the students to compare and contrast various differential diagnoses. Very important because we want to distinguish between two diagnoses and distinguish the very salient features. So we can ask them to compare and learn from that. So reflection, categorizing and building, contrasting the differential diagnosis. We can ask the students to explain the reason why any further particular information is being sought and how they arrived at a particular conclusion. And we should do that in a very non-threatening manner. This allows the teacher to understand the clinical reasoning approach of a student while making a diagnosis or a management plan. We should be very much inquisitive, and we should ask that why you think that this particular diagnosis you have reached upon, what you if he is asking for further tests or investigations, why you are seeking this information. We should try and analyze how his brain is working, and we should learn from that and encourage or correct him wherever necessary. We should encourage the reading habits, that is a deep learning rather than rote memorization, and we should provide a very formative feedback and time for reflection upon that particular feedback in a non-threatening way. Teachers to share their own logic and analytical process on the given case. If we share our reasoning process, then it becomes very, very clear to them as to, we demonstrate the clinical reasoning approaches, how the expert works, and becomes very clear for them, and they can follow the same pattern. We can ask them to summarize the case in 2 to 3 sentences. Now, this will encourage comprehension and synthesis of information. We should give them opportunities for repeated practice. This will encourage the deliberate practice, confidence in dealing with diverse contexts. So our own process we should share, we should ask them to summarize, and we should give them opportunities for repeated practice. So these are all the various teaching strategies, and also there is very, very important one, that is 1 minute preceptor, OMP. I'm sure all of you must have heard about this, wherein we follow a particular pattern. The resident or the student presents a case, and the faculty listens and clarifies, and then the learner, we have to ask for the commitment from the learner and probe for underlying reasoning. And then in the last segment, we have to provide a positive feedback, correct the errors, and teach the general rule. So diagnosing the patient, the presentation happens for 6 minutes. Diagnosing the learner, that is asking for commitment and probing for the underlying evidence, for 3 minutes, and giving a positive feedback, correction of error, for 1 minute. So this is the process that we follow. And in this process, what we do basically is getting a commitment and probing for underlying reasoning, and then providing a positive feedback, correction of errors, and teach the general rules. So we are teaching, and we are also diagnosing the learner. So this is the micro skills of OMP. So sir, you would like to add something on this?
No, I think these models, some of times we use them day to day, but I feel we should do it more consciously. And if you follow it in your day-to-day practice consciously, that I want to build in reasoning in my patient, I'm sure that will happen. Next.
So give them assignment that how they will embed this in their daily practice.
Okay. Yeah, I think you can do that. What you should really do, take about, say, one case in a day, see that you ask somebody else to look at your way, how do you conduct a case, and then you take a one-to-one feedback from your colleague that did I do all these 5 things together? That may be the best way you can learn these skills. Then the feedback may be given, yes, you did this 1, 2, 3 well. 4th, you could have done this better or something. Your close friend can really do this for you. And that's the way you built upon this kind of an skill in your mind.
So there is another model, that is SNAPS model for structured case presentation, wherein it is an acronym. So summarizing the case, narrow the differential diagnosis, analyzing the differentials, probing the preceptor about the uncertainties, plan management for the patient, and select case-related issues for self-study. So this is the SNAPS model for structured case presentation that can also be followed very effectively to build clinical reasoning skill.
I think there are now, if you see, a lot of clinical resources during the pandemic are available, and clinical key student is one of them. Like you have books, videos, and images. Next slide. Something like this hepatology case, there is a case which is already built in, and then it has all these questions. How do you really follow? If you go through these, there are a number of cases now in each subject which are available for clinical student. I think there is a clinical key student is available. And there are so many cases available like this, which are already built up. Plus, there are answers which are also there. Are assessment questions which are also there. You can assess your student, what he has done well, what he has not done well. And all these resources, which are online resources, can make your job much simpler. You don't have to build up cases now. They are easily available to you. You get an answers. So these are the something which you can do. And I think if you really see, let me ask you this question. A man pushes his car until he reaches a hotel. When he arrives, he realizes he's bankrupt. What happened? Can anybody answer this question?
You can raise your hand or just unmute and answer.
Rekha, don't look so puzzled. Yes.
Niranjan Divekar.
Because his car was banked by another car. Okay. So the value of the car got less.
Yes.
So he got
Niranjan,
bankrupt.
Yes, you are being very. Yes, I think go to the next. He was playing Monopoly and his piece of car, he lands on a space where the hotel and does not have money to pay the fee. It's such a different way of thinking. Now, what I wanted to show was lateral thinking. Lateral thinking is one of the way by manner of solving problems using an indirect or creative approach via reasoning. And what we used to do, that if a person is going linearly and he finds something which is blocking, it's best is to take a lateral turn and go ahead. And this is what one of my bosses always taught me. You must really think in a clinical practice. Sometimes, all these solutions are not given in books. So you have to think on your own and you do it. So there's a traditional logic and lateral thinking logic. So there are a lot of sites. All of you play Sudoku. I don't know. I play because I probably want to avoid dementia in my future. Yes. But if you realize, if you play Sudoku, you start developing mental shortcuts in your mind. And I think all of us should really understand that we should have some kind of a lateral thinking all the time. Every time you should not think laterally, but sometimes definitely you have to think about lateral. Yes, Sai?
Yes, so how do we assess clinical reasoning skills? We have a lot of options here in the literature. We have multiple choice questions, which are recall type, which can be higher order scenario based to test the problem solving ability. We also have extended matching type of EMQs questions that we can ask in our theory papers. As for the practical evaluations, we can have mini clinical evaluation or mini CX, wherein we can have various settings such as outpatient, inpatient, emergency, or skills lab, and number of skills can be assessed. So interviewing, physical examination, professionalism, judgment, counseling, organization and efficiency, and overall clinical competence. So out of this, I think clinical judgment is the skill that can be tested by mini clinical evaluation. And a very, very important feature with mini CX is that we give the feedback, and we not only give the feedback, we rate the satisfaction of the resident with the feedback. So a beautiful tool. I'm sure all of you must be aware of this tool, mini clinical evaluation. Then we have a script concordance test that can be also used for this test in developing or assessing the clinical reasoning. What happens in this is that this is based on a principle that the steps in the clinical reasoning can be assessed and compared to the reasoning ability of a panel of experts. So whatever the student, the performance of the student is, and whatever his reasoning ability, whether it matches or whether it is in concordance with your expert panel, that is being tested here. So this test design conforms to the possible organizational structure of illness scripts in the minds of experts. So step one is a short, ill-defined clinical scenario is first provided, and the examinee's opinion is sought in terms of diagnostic hypothesis or investigation or judgment. In step two, a new piece of information is provided, for example, a clinical feature, a test result, or a disease progression, etc. And now the examinee is asked how this new piece of information affects their initial judgment. The decision-making process of the learners is reflected in their responses at the addition or availability of each new piece of information. Now, these responses of the learners are scored using the responses by a panel of experts on the same case as a reference. So a bit tricky to conduct, but then I'm sure when you do it for a couple of times, you will really like this kind of an exercise, script concordance test. I will share the reference. I have used this in my clinical setup. So I will share it in the LMS, script concordance test, and how to go about it. Now we have workplace-based assessment, wherein a number of tools are available, wherein we can check the clinical reasoning ability if we are using the logbooks, and if the logbook can be made into a portfolio with the addition of reflection component and a feedback component. That also can be a very good example. We have DOPS, we have various other tools, OSCEs, we have MCQs, which are scenario based. So a lot of tools here. Sir, you would like to add anything?
No, I think all these tools are there, but it's how creatively you use them to introduce the reasoning. That is very important. These tools are just list of tools, but as you said, how do you use creatively portfolio to find out a particular kind of an lacunae or something which is not good, and then train him in that particular way, something like that. And then you say, okay, he missed this diagnosis 10 times. Okay, then you ask him to do go into more cases, give him simulations, do something like that, so he does that better, something like that. That is more important. So diagnosing his weaknesses, diagnosing the learner, and then giving him experiences by which he will learn more is the way you have to really do this.
Right. So unlike here, I would like to add, unlike our, the cognitive skills and psychomotor and affective domain, this clinical reasoning requires a lot of effort from the part of the teacher as well as the student. And it is very much, specific to specific learner. So there is no one particular strategy which will fit to maximum number of students. So we have to be vigilant. We have to see what are the needs of that particular student, and then choose the appropriate strategy and corrective measure and assessment tool. So,
okay. So
yeah.
what are the other issues with clinical reasoning? I think we are coming to the end of our session. Next slide. Do you know any other issue? Next slide. Say yes. See, basically, there are always, when you make a decision, there are 4 types of situations. One, you have certainty. One, you have uncertainty, and there's a conflict, and there's a risk. That means if you make an uncertainty about that, and there's a conflict between the two decision making, there's some amount of risk which we are carrying. And this is very important. For example, let's go into the next. So you have to look beyond evidence in sometimes, and subjectivity cannot be replaced by objectivity. Remember that. Sometimes looking at a patient, you would say, no, in this particular patient, this is not going to really work because of these factors of your experience, wisdom, which is very important. And apply clinical expertise and see the impact it on patients. And that is very important, So go next. So you have to sometimes balance between quality and quantity. This is something which you have to do in a clinical decision making. Next slide. For example, there's always a trade-off. For example, look at this. Somebody has undergone a knee replacement and he is happy and his quality of life is so much. After doing a knee replacement, his quality of life goes down or something like that for few years, few hours, few months, 3 or 4 months. And then again it comes up till some age, then it really goes down. So for that 3 months of period of time, he has to go through that pain, disability or something to get 10 more years of good quality of life. So there's always a balance which what you call as a trade-off you continue to do in any kind of a decision making. Next slide. So the same thing I wanted to show, that when somebody is undergoing anticipated health profiles in a TKR surgery, if there is a dip in your first 3 months, but after that you have a better quality of life. But if you don't do anything, you will continue to lose your quality of life. Now he has to decide, yeah, I'm not going to undergo surgery. I'm going to continue remaining at a low level of life, while if I do surgery, I will have some problems in the beginning, but then I'll have a better quality of life. So this is a decision which you need to convert. Secondly, a cost-based decisions. CA colon, if somebody had 5FU has 2,000 rupees per cycle, and monoclonal antibodies have 1,50,000. And if you see the percentage benefit over treatment in a systematic review is about 2% or 3% in the overall. So a person who is not really affordable, he should not sell his house or sell his savings to get that benefit. These are all individual decisions, but sometimes you have to be very rational, because there are all market driven decisions. If sometimes you find 80-90% of age person comes to you, then you have to really balance. Why give him unnecessary extra chemotherapy rather than giving a basic chemotherapy like Folfox or Folfiri, rather than giving, because it may not really affect his prognosis by 1 or 2%, which if a rational family accepts it, then you can do them. But if somebody says, no, I want to spend, then okay, this is what we are going to tell you. You take the decision, but we should be able to explain patients the cost-based decision making. Next slide. So some argue that cost should include all future costs and savings if you do. So there are two types of interventions: life extending interventions and life saving interventions. So somewhere where you are saving a life, usually you would like to go for everything, but life extending interventions become less cost effective because they are life enhancing interventions. So you have to really think about emotional aspects of a family, that particular person. There are so many decisions which you are involved, and look at our day-to-day life decisions, and you will realize that these are the kind of decisions we have to take in our daily practice. Let me have another example. 60 versus 30% burns. You have only one bed and resources are treating only one patient. Which one you will treat, 60% or 30%? Now, a 30% young, better nutritionally patient is a better deal because you will be able to save her. 60% poorly nutritional patient is anyway will die. Now, if you have only one bed, you will try to save 30%. Now, this sometimes looks a very very decision which will say, okay, how can you really refuse and all? It will come in newspapers. But remember, in a health, in your mind, you should be able to cross over these sentiments, and you have to also understand that this is what it is. You are taking other decision only because of whatever other reasons you have. Next slide. So how do we acquire wisdom? This was something somebody was asked me. So this was a very good cartoon. I said, what is wisdom actually? Wisdom is something like, you know that tomato is a fruit. That is a knowledge. But do not put tomato into fruit salad because it's a fruit. That becomes a wisdom. So you have to balance your knowledge to wisdom. So that comes only by making mistakes, learn from your own mistakes, and repeat steps 1 to 3 until the wisdom is acquired. And if you still don't learn, then realize that the wisdom you acquired in step 4 was not really the wisdom, which happens many times. And therefore, what you do, you continue to go on repeating this steps throughout your life. So we continue to go on and repeat our steps to get wisdom. And that is what we really value as a teachers. As a teacher, at end of your career, what you have is a wisdom. And that is what we should really do it by reasoning and doing it. So I think we have come to our end of our presentation, and we have about few minutes where we can take questions. Otherwise, we don't want to exceed our time. You can put it in chat boxes and we can really answer all those questions, and Sai can correct it and send it to me. We will answer all your questions if they are in the chat box.
So I have one comment from Dr. Sanjay Prasad. He's saying it will better, sir, if one such prototype scenario is demonstrated. So, sir, in which context you are talking about this prototype? Dr. Sanjay Prasad.
Skill, madam.
Huh?
Learning clinical skill.
Okay. Learning clinical skill or clinical reasoning?
Reasoning, actually. Excuse me, sir. Fine, reasoning.
Sure. I think what we will do, we had anyway planned, we are going to give you some resources. We will send you an article or something so that you will get a better idea about this. And after reading that article, if you get still more questions, you can still contact us.
Okay, sir. Thank you, sir.
One more comment. Do we have any strategy used in various institutions for teaching and assessment?
No, I personally feel this is one area where individual teachers are using as their own. There is no specific curriculum. to be very frank, I learned about clinical decision making only that is a science, and there's an association, there are books, only when I did a course somewhere in 10 years ago. I mean, in spite of being in a clinical situation, I thought this is one science which has never been explored. You know, we do it every day, but we still don't explore this clinical reasoning and clinical decision making. It's a totally psychological subject, you know. It's a psychology and logic is mixed together. So there is now the whole science of medical decision making. You can go through, there are journals on this, clinical decision making, medical decision making. There's a very nice book of Dr. Schwartz. Somebody asked me any book. Alan Schwartz, he has a very nice book on medical decision making. So if you are able to get, if I'll see whether I can get PDF in a Z library, otherwise it's a costly book. So if you're able to get it, I would advise you to read that book because itself is a wonderful read, you know. Another thing I would ask you to read is, there's another book by Adam Grant. It's a book on, you know, something, Think Again. You know, Adam Grant is a great writer.
Yeah.
So you can write about him, Think Again. And he talks about rethinking, how do we make decisions and how do we want to think about, you know. So these are all cognitive processes in your mind. How do you want to change? And we should all learn to change our cognitive processes for something which is reasoning. You know, and all of you, I would like you to reflect. I would like you to introspect and see every step of your day-to-day life and see how you can promote. Because if you are able to master this, it makes a lot of difference between others and you. So I think I would like you to really go through this process and learn this art so that you will be able to go through this.
So what I think is here, you know, artificial intelligence can replace the skills or, you know, even the other aspects. But then this clinical reasoning, I think this is a characteristic of humans. And there we don't have any competition. So I think that is what, you know, describes us.
Artificial intelligence will give you choices of decisions in such a situation. It will tell you Dr. Nagda would have done this way in this particular situation. Would you like to follow the same path for this patient?
Yes.
We only have to say, you know, we have now a medical Alexa, there will be surgical Alexa, and I'm sure there will be a dental Alexa in soon. So you will have to ask her, what should I do in this situation? So they will tell you, yes, I did this in this case, you would like to follow it. But remember, there is a limitation to AI. So we have to really you keep the human component there inside your image.
And another issue I would like to tell here is that in our dental institution, private dental institutions, we always face this problem of clinical material, enough number of and variety of clinical cases. So herein we can use those, you know, digital form repository of cases. Like sir said, that you build a context specific case. Suppose I want to address the socio-economic issue. Suppose I want to address a biological issue. So I build a specific case with a clinical picture and everything, keep it ready. And if not an actual patient, I expose them to the digital format. So that is also a very good strategy for private dental institutions where patients are less.
Fine, sure. Okay, madam.
Yeah, yes, sir. Thank you. But
sir.
I want to tell you that it was a brilliant presentation because in a short time you covered a lot. And we talked about metacognition from the day one, sir. We have been talking about metacognition. We have been talking about critical thinking, but it's all about how they will convert all this, what they learn in daily practice. So we are emphasizing on them covering on one scale, end of the pendulum is just giving the students steps in complete denture, partial denture, or, you know, even the MDS exam says that short case, long case of specified, you're already giving the treatment plan. But on the other hand, sir said about critical thinking and being creative. So in between that, there are many things we need to teach the students is, yes, a complete denture patient, but each patient is different, as Sai had shown. The spectrum is so much. So how can we integrate? And I think Sai will put up a right assignment asking Dr. Supe about it. And aptly, the next talk is by Dr. Mahesh Verma, and it is on artificial intelligence. Sir, it is so much connected now. So over to you, Mahesh. And before that, though all of us, he's a prosthodontist, you all know him very well, but all the same.
Madam, I have to leave because I have a thing to do.
Yes.
But I want to listen to Dr. Mahesh Verma's talk, so you can really record it and send it.
Sir, I'll send it to you. I'll ask you to send it to you.
Sure,
Yes,
Mahesh,
sir. We will send
bye-bye.
the recording, sir.
Sure. Take care, sir. Take care, Mahesh.
Thank you, sir.
Thank you, sir.
So Dr. Mahesh Verma is currently Vice Chancellor of Guru Gobind Singh Indraprasth University, New Delhi. Earlier, Professor Verma was the Dean of the Maulana Azad Institute of Dental Sciences, which was declared a Center of Excellence and is the best ranked dental institution. So many years we have been seeing the rating of that institution. It's all credit to Dr. Mahesh Verma and his team. He has been the president of IADR, IARD, and also he is also a Famer Philadelphia Fellow. He also has the FDS RCPS from Glasgow. Mahesh, we share a lot of common things. And also he is the Fellow of International College of Dentists and Dental Surgeons, American College of Dentists, and American Academy of Implant Dentists. So it's in a very long CV, but I am very proud to have Dr. Mahesh Verma. See, he's very dynamic. You know, when Mahesh is there, there is life in the IPS, and also he has got some charisma in him by which people listen to him, isn't it? And all of us love him, isn't it? So without taking much time, I will hand it over to you, Mahesh. Probably a couple of months later, we look forward to you doing a session on interprofessional education. Both of us will do it combined, because you are in a university where so many subjects are there. And I think these people should have a taste of that. Over to you, Mahesh. Yeah, you can share.
Thank you. First of all, am I audible? Am I audible?
Yes, sir.
Yes, sir. Okay. Yeah, because I'm not very good at computers.
Yes,
I usually take help from my staff here, but now I'm at home, so I'm just going to share my screen. Let me see if I can do that. Yeah, my screen is
yes,
now?
Yes,
Okay.
Yes, sir.
Yes, sir. Yes, sir. Visible.
Yes, sir.
That's fine. So yeah, let me minimize that. So first of all, let me congratulate my dear friend Professor Nagda for starting this endeavor course on dental education, especially focused on our dental colleagues, and also thank her for pulling me out for this session, because she's sounded me much earlier, and to ensure that I'm here. So here I am. And when she asked me to give a lecture or share my thoughts with you, she gave me two options. One was interprofessional education, and the second was AI, artificial intelligence, and health professional education. So I chose this topic, for multiple reasons. One, of course, I'm not an AI expert. I'm also a beginner trying to learn, trying to understand. But, lately I have been involved for AI working committee at FDI, and also had opportunity to speak on this topic a couple of times at some occasion. So that interested me, and I consented that I would be speaking on AI and health professional education and how it can lead to a smarter future. I think we are all looking for, a future which is brighter, exciting, which is much more fulfilling. I feel that AI is such a hype today, everywhere. I am a part of a university system. You talk to any specialty, any area, everybody is talking about AI, and they're so excited. Other day I was thinking, it is as exciting as stem cell research. When stem cell research happened, I think every specialty wanted to incorporate it. And so it's so exciting. And, also artificial intelligence is part of 4.0 revolution. So it is a revolution. And it's very hard to think that there is any area which is not affected by AI. So it's a technology which is we can call nascent driven technology, and it has a huge impact in healthcare because we all, fortunately, we are connected with the healthcare. And also, I wish to make it very clear here that, see, when we say healthcare, the health education and the healthcare delivery, both are connected. We cannot segregate it. So when we are talking of education, as Professor Supe was giving so many examples of, of decision making, so it is always, there is always a, clinical relevance. You cannot, like other streams, you cannot separate education from the healthcare delivery. And I think the stage today is set, totally changed for education. The demand had changed, the need had changed, and the scenario had changed. So it's a good opportunity for all of us to bring out and utilize, seize this opportunity to utilize AI and prepare for the future. We are already struggling, for equity, for access, for outcomes which are predictable, which are much more safer, which are much more successful. And so using a smart technology for a smart future. So keeping that in mind, but before I begin, I like to say a couple of things. One is that, as I already said, that healthcare, education, and care are interconnected. So when we are talking about education here, it is not just pedagogical learning, but it's also clinical learning. When you are using a technology, you are also learning clinically. The second thing is that we will be just talking about some concepts of AI, because many of us have no background of engineering or some such sort. So we need to little bit understand what are the different concepts of AI, how it is going to impact the medical and dental care today, and what is going to happen in future, in coming times, and what are the challenges and issues, to even it out. So, this is possibly more of an introductory lecture or introductory sensitization about AI and how it is going to impact our medical or a dental education for a smarter future. So let's start. Can intelligence be artificial? Isn't it? Intelligence, we always thought that intelligence was a domain of human beings or even animals or even plants. Remember that touch me not plant? The moment you touch it, starts shrinking. So
Yes.
it is only, it was only a domain of living organisms. But today we have machines which work like human beings, which react like human beings. So AI is when machines mimic human cognition, when they kind of do things similar, which is done by human beings, and we use them for learning and problem solving. So there is nothing artificial about it, because it is built by humans and will ultimately impact human lives and human society. So let's talk about how it all started. Most of us think that this is something new. No, it is about 60, 64, 65 years back when, there was a conference in US between IBM, which is a computer manufacturer, and a Dartmouth Ivy League college, where this term was coined by John McCarty. If you look at the picture, the third person from the left is John McCarty, and look at these notes, which are handwritten notes at that time during that conference. And the excerpt from the conference was an attempt will be made to find how to make machines use language, form abstractions and concepts, solve kinds of problems now reserved for humans, and improve themselves. So it's a concept which is not new. It has been around for a long time. And if you look at the AI timeline, and we will not talk about all the milestones, but look at the first industrial robot was made in 1961. Imagine, almost 60 years back. And it was used by GM company, replacing humans. And in 1964, Massachusetts Institute of Technology, Boston, they made the first chatbot who was talking like a human, talking conversation with the human beings. 1997, the Gary Kasparov, which was a champion, chess champion, was defeated by a computer called Deep Blue. So that proved that computers can have a similar thinking like human beings. And 2011, iPhone, Apple incorporated Siri in its 4S series of phone, which is a virtual assistant kind of a voice interface. And 2014 Alexa. Just now Dr. Avinash Supe said that we have a surgical Alexa now, we have a medical Alexa, and I think soon we're going to have dental Alexa. So it has been, it has been an evolution, but it has been around for a long, long time. So what can AI do? I think AI can be really transformative. Remember that when the human being evolution happened, what really changed us? Fire, steam, electricity. It changed our life, the way we live, isn't it? I think AI has already impacted us so much, and it is going to really galvanize all the different domains for human lives in coming time. So it's really going to be very, very transformative. It's going to change, and I think healthcare and health education, medical education, dental education would be equally transformative. So let's understand the rise of AI through this video.
Medicine and what that entails. Think today about the largest car company in the world. Uber doesn't own a single car. Think of the largest hotel chain in the world today. Airbnb doesn't own a single hotel. The biggest medical systems in the future are going to own no hospitals. It's going to be devices that are monitoring the lives of millions of patients simultaneously, that's looking to see if you have the beginning signs of a cancer emerging, to not treat the cancer, but to prevent the cancer from ever occurring. Like that day is definitely coming. Big data's impact on the practice of medicine is fundamentally going to transform the physician's ability to personalize care directly for you. And the way we're going to get that is you have a handheld device that has amazing capability in Bluetooth-enabled inhalers for asthma patients, scales, blood pressure monitors, EKG devices. The sequencing of the human genome. That first genome cost us $3 billion to sequence. Today, you can do it for $1,000. We're going to have individualized models for each person that maps out their health course trajectory. It will be something that you're engaged in on a daily basis, but not necessarily actively. You're just being triggered if you need to be, because the algorithm says, okay, you're at super high risk in the next year of progressing into type 2 diabetes. So if you can catch that before the catastrophic state, then the person's not having to come into the hospital. I think we have this shift in culture that says, being more open and sharing is good, but medicine hasn't kept up with that. I guarantee you what's in my Gmail is far more personal than what's in my medical record. The data has to be more accessible. The ultimate end game is you have this personalized therapy specifically tuned to who you are, the stuff that's going on inside of you. If the physician can know that, they can better serve the patient, better serve the health system, and it benefits everybody.
So I think this video has shown that there is a tremendous impact AI has made in healthcare, and I think time has come when we are targeting treatments which are very specific, which are very targeted, which are very individual based. And when you're comparing human intelligence and comparing artificial intelligence, how it is processed in a human intelligence, as you all know, we perceive things. It is interpreted in the brain, and there's a result. In artificial intelligence, we have two systems. One is a machine learning, which is a kind of a basic artificial intelligence. Basic when we say compare it with deep learning, because deep learning is much more intense. So machine learning, there's a data which is fed, and human engineered features, which is the domains of the computer, and there's the feature learning, what particular particular action which it is expected to do. That's a machine learning. Whereas in the deep learning, there is a feature learning and mapping. So feature learning is common, for that particular feature, for that particular action which is expected from that computer, which is part of artificial intelligence. But it also has a mapping. That means deep learning is much more intense than machine learning, and it has the ability to classify the data, structure the data, for a later use. So that is the difference between machine learning and deep learning. So the difference of intelligence, human intelligence and artificial intelligence, is that here we are using computers and which are fed, which are programmed, and the action happens. And also, when we classify artificial intelligence, it can be two types. One can be a strong AI, which is more like a human brain, where which is capable of dealing with a lot of unfamiliar tasks or complex tasks, to find a solution. Whereas weak AI is a very narrow AI or AI system that is trained for a particular task. For example, our Apple Siri, it asks you ask something and it does that. So there is a difference. So strong AI is more like human intelligence, and weak AI is more like a particular a singular or something which is a particular problem solving ability. So that is the difference between strong and weak AI. Now, I mentioned about machine learning and deep learning. What's a machine learning? Machine learning is something that the system, which is a computer, it has the ability to automatically learn as it is, as it is dealing with more and more data. Like all of us, when we grow, we become senior, we become more intelligent. I think somebody, just a couple of minutes back, we were talking about reasoning and intelligence. And so computers also become more wiser. They become more intelligent because they're dealing with more data. And that data is giving them some further intelligence. So that's a machine learning. And we are using this technology, this feature, this attribute of computers in diagnosis of diseases, which are otherwise very hard to diagnose, because human beings, of course, they are good, but there are many things, they still have a limitation. There are some conditions which cannot be visually or which cannot be diagnosed, which can be very easily done through artificial intelligence by the computers. The deep learning is an evolution of machine learning, which it has got a different set of computers, a collection of computers, or collection of neural networks, something very similar to our, like a human nerve network. And by deep learning, it's capable of learning from data that is unstructured or unlabeled. See here, because what happens is deep learning is much more intense. Here, what happened that it can deal with data which is unstructured, which has got a lot of data, and it can streamline it, it can structure it, and it can infer, it can make a meaning of it. So it's a deep learning, more like human beings. And representation learning is actually part of deep learning. What happens that it's a subtype of machine learning in which the computer algorithm learns the features required to classify the provided data. That means, feature means what that computer is being used for, that feature that is, for that particular action. That is representation learning. And this does not require a hand-labeled data like machine. In machine learning, as I said, is like a beginning, but deep learning, where the data is very complex, unstructured. In machine learning, the data is hand-labeled. We are programming it. Whereas in a deep learning, a lot of data is fed, and it come out with a feature or called a representation learning. Then what is artificial neural network? As I just said, that it involves a network of highly interconnected computers, just like nodes in a human nerve system. So this, why we do it? Because this network of interconnected computers has the ability to learn from what has happened in the past, analyze non-linear data which is unstructured, which is not linear, and it can handle a lot of information which is scattered, imprecise, and it can generalize it, and enabling application of the model to an independent data. Now look at these. In a computer is trying to understand this picture is of a dog or of a cat, and then input, there is a network of computers, and then it is giving information that this is a dog. I think we just now talk about clinical decision support system. I think we were talking earlier in the earlier lecture. I just heard that the best part of artificial intelligence, as Dr. Supe said, that if there is, the computer will only tell you what Dr. Nagda has done in this situation, or Dr. Sai Deshpande has done in this particular situation. So, but it does help you. It does help you what should be the line of treatment, or what should be the differential diagnosis. The best part of clinical decision support system is that it is actually collecting the data from the patient, how the patient is presented when the doctor is examining it, physician seeing the patient, final treatment is being made, the data from the lab, data from repository, all that is collated, and a decision made. So it helps you. I think it helps you making an improved diagnosis which is much more accurate, and supporting you. In fact, it becomes so difficult, and also is giving you information about data which is there in a depository. Just now, I think Sai was saying that when there are cases, biological situations or social situations where you make a case presentation and keep it as a data and share it with others, something like that has happened in a similar situation in early instances. So clinical decision support system is a very popular kind of system which is being used by computers, which is part of artificial intelligence. Another concept which we are using is augmented reality. Augmented reality means it is something which is enlarged. It is a real thing. It's a real picture, but it is a time to work in a very narrow spectrum. So it is an enhanced version of a real physical world. We are able to dissect organs without any mess, or we can study in detail anatomy, physiology, and and if you merge it with the auditory or a visual information, it can be more it can be more fulfilling, and it can enhance the experience. That's an augmented reality. And especially for us, we work in a very narrow area of oral cavity. It can really help us in understanding concept and understanding many procedures in the mouth. Another one is a virtual reality. Virtual reality is something which is a simulator, which is fictional reality. It's a computer-generated environment, and here we are using completely virtual simulated experience, reenactment of a 3D image or of the environment. And here, the ability to see inside the body, something which otherwise is not. So it's a virtual. It's something reality but virtual. You see inside. I'm sure many a time we wear those virtual glasses, and then it gives you a feeling, or you've gone to Disneyland or something where they make you sit in a chamber and they make you feel as if you are flying, but you are stationary. So it's a virtual reality, something which is real, but it is virtual. It's only an environment which is created. So that these are some of the concepts which are used in artificial intelligence. So what are the three arms of artificial intelligence, which is very popular in healthcare, and we can, if we say also to the health education, one is machine learning. As I said, that machine learning, which can help us diagnose the conditions. robotics, which can help us doing certain procedures. And another arm, which is very popular, is natural language processing. Today, we don't have time to write notes, or we can dictate notes, and there are softwares which will convert the voice messages into text messages. So let's see machine learning. As I said, machine learning is when the system automatically learns from experience without being programmed. You've not programmed it. You programmed it, of course, in the beginning, but as it is getting richer in experience, is seeing more and more information, it is becoming intelligent. In healthcare, ML, machine learning can identify and diagnose diseases which are otherwise very hard to diagnose, especially in radiology. And also cases where early stage drug discovery, because one of the application of AI is early stage drug discovery. So there also machine learning can help us a lot. Another one is robotics. I think nowadays robots are becoming quite popular, even other than healthcare. And surgical robots, a lot of things can be done by the robots doing a lot of surgical procedures. And then other robots are care robots, like patients which are elderly, which have got some disabilities, persons with disabilities, or geriatric patients. Their robots are taking care of them. And then there are other kinds of robots which are exoskeletons, which help us assisting patients help patient rehabilitate from conditions which are very which have like limb disorders or some spinal cord injuries which are bedridden, and or have some strokes, where these exoskeleton robots help them carrying out activities, because otherwise very difficult. You need a human being to someone to assist them. And natural language processing, as I said, the third arm of AI, which is very popular, is where it is we are using computers to parse human language, divide it and resolve it as we humans do. And speech to text conversion happens in prescription writing, where the text data or the electronic health record, the text data which is embedded in a EHR can be read. It can be read by the computer, or text to speech. There's a text there, and that can be converted to a speech by the healthcare bot. So these are three arms of AI which are very, very, very prominent as far as healthcare is concerned. So what can AI do for healthcare? As I said, that we are firstly talking about healthcare, and then we'll talk a little bit about health education or dental education. So scope of AI in healthcare is very tremendous. Actually, if you look at kind of specialties which has grown in the recent time, and all the different procedures which are undertaken in a healthcare setup. So AI can mine the data, it can collect the data, it can look for hunt the data, and it can recognize ability, which is to adequate methods for patient care. Because we can use the data, how we can help it, which can help the patient care. And it has a major role in diagnosis of a lot of conditions. It can collect the data in a very structured way, and patient examination can also be assisted by AI. Assisted with the physician. It can also its role in R&D, research and development, and I think it can be very efficient. So a lot of tedious tasks which can be undertaken through AI, so it saves time. And I think also overall the treatment cost can contain cost, and so it really promises to make healthcare more participatory and more effective, more efficient, and also less costly. So let's see, what can AI do for healthcare? One is prescription writing. I already said that we have bots today which are being used by physicians in the form of voice notes. So there are digital assistants. So when the patient is taking, the physician is taking round, and he's saying that, okay, he's giving the notes, clinical notes, and directions for the treatment. I think the digital assistant are taking notes, and it is being recorded. So that's very popular. It's being used. Another one is image analysis and diagnosis. I think this is one area which is really AI has helped a lot, especially in life-threatening conditions, time-sensitive condition where we want the diagnosis early, otherwise it can impact patient's life. So early detection, it can improve clinical diagnostics and targeted diagnostics, where a particular, because instead of becoming a very generic, a very specific kind of a diagnostic, this can be done using AI, especially in image analysis. So image, when we're talking image, we also talk about radiology. Of course, it cannot replace human beings, because radiologists, pathologists, they are the one who diagnose a wide variety of conditions, but it has been proved that it can perform as well. So, if the AI can really help, it can really not replace, but it can certainly supplement radiologists and pathologists to diagnose a lot of conditions, and spare radiologists, pathologists to do many other activities. Then it comes to in surgery. I think I already talked about surgical robots, and the advantage is that you can control the trajectory and depth and speed of the movement with precision, because a lot of procedure in surgery, heart and cardiac and neuro, and a lot of in spinal surgeries, I think precision and speed and depth is very important. So all that can be done by the robots, and many a times, because human beings can have tremors and there can be unintended movements, accidental movements, that all can be avoided. But the only limitation is that it can only carry out procedures which are same, which involves repetitive movement. So it cannot, on its own, it cannot, yes, of course, when it is collaborative, that means where a robot is working with a physician or a surgeon, in that case, it can be win-win both for the surgeon as well as for the patient. So another is a drug discovery. Drug discovery is a very, very, very challenging area, and it is so difficult to come out with the new molecules and assess the efficacy of the drugs. So it can, the compounds, it can assess the effect of a compound on a targeted area, and AI can really be useful in drug synthesis, drug design, drug repurposing, which is part of pharmacology. So especially in conditions like oncology and neurosciences, where drug discovery is so much vital and so much important. So let's see.
Once thought a futuristic threat to humankind, AI is changing and saving lives. Not intended to replace clinicians.
Dr. Shuchi, can you mute?
AI serves the purpose to enhance and complement the very human interaction of provider and patient. In healthcare, AI is changing the game with its applications in decision support, image analysis, and patient triage. With their ability to reduce variation and duplicate testing, decision support systems quickly decipher large amounts of data within the electronic medical record. AI technology is also taking the uncertainty out of viewing patient scans by highlighting problem areas on images, aiding in the screening and diagnosis process. Artificial intelligence helps with the issue of physician burnout by collecting patient data via an app or text messaging. Chatbots now ask patients a series of questions regarding their symptoms, taking the guesswork out of self-diagnosis and saving both the patient and provider time and money. With the AI integration, working smarter enables solutions to a variety of issues for patients, hospitals, and the healthcare industry.
So, from all this information, you all will agree. I think the tremendous is vast, and the scope is enormous because, look at that. AI can read almost 1.3 million research articles, which is indexed by PubMed each year. It can examine 1.5 billion Facebook users, monitor 500 million tweets of people who are suffering from some kind of diseases, and AI can interact with each and every person seeking answers to their health question. All of this on a daily basis. In one day, all this can be done through AI, and this was recently reported in a paper which was published in Canadian Community Disease Report. So, I think the scope is tremendous, and it's really enormous. So let us look now what AI can do for us, for dentistry. I think it is all the more relevant, as Dr. Supe also said, that we need a dental Alexa, because dentistry is something which is procedure based. So I think it can be more relevant. Dentistry also need precision at every step, and it's labor based. It's very labor intensive. So I think AI has tremendous role and scope in dentistry. So let us look what AI can do for dental specialties. And if you look at all these, I think it can do, it can do so much in dentistry, from dental caries to fractures to lesions to salivary glands to, cysts and cancers and metastases, so many. It has a tremendous scope. It can do so much in different areas of dentistry. So let us look one by one. General dentistry. I think, we have seen, when we were students, there was dental chairs which were hydraulic, and then, later we saw electric chair with sensors. Now we have voice command chairs. We have chairs, along with the chair, there are virtual dental assistant. So, AI can help us scheduling our appointments, alerting us about any medical history, or alerting the patient about their checkup, which is needed from time to time, or any genetic or lifestyle information which a dentist might need. And it can create a database about all the medical history or allergies of any such similar issues of our patients. And it can, really make our clinics paperless, without any paper, everything digital. And oral surgery again, a lot of planning surgery, navigation surgeries, which can help us preserving vital structures, and very accurately guided surgeries, so that there is no need to revise procedures. And also, a lot of it's more like like a GPS or a CT guided surgeries, and bioprinting for regeneration of oral hard and soft tissues. I think through SLA, or through solid free-form fabrication, powder fusion printing, and laser assisted bioprinting, all those things. But still, I think we have not been able to print print hard and soft tissues, which has a right kind of characteristics, or right kind of properties or strength. But I think it's in pipeline, and very soon we shall be able to do that. And in oral medicine again, all especially suspicious pre-malignant and malignant changes, we normally look at it clinically, and I think the AI can help us diagnose them better, especially oral cancer, predict a genetic predisposition of some of our patients with AI. And similarly, in radiology, as I said, that a lot of with the imaging, it can help us not only in the jaws, but also other domains like in endodontics and location of apical forum, all those small things, working length, all those things, proximal caries, is otherwise very hard to diagnose. And forensic odontology is another area, I think so much, because forensic odontology is one area where age estimation, all other things, records, pre and post records, which we can retrieve anytime. And, all those things can be very easily done with the help of AI. Orthodontics is another area where we have to monitor how the progress of the treatment is going, how much will be the tooth movement, predicting tooth movement. Nowadays, I think, customized aligners, that's another area which is very, very popular. And what will be the final treatment outcome in orthodontic cases? Periodontics also, I think, a lot of areas, and especially I would like to talk about detection of peri-implantitis. I think, again, with the big use of implants, this is one condition which is very common, and it can really help us assessing it and what intervention can be done for these cases. And prosthodontics, I see a lot of prosthodontics connected here. We are using this AI for digital dentures, 3D printing of restorations, all the virtual articulation. And very soon, I think we are going to have tooth preps, which will be done by a robot. And we already printing maxillofacial prosthesis with the help of AI, and training, talking about simulation haptics. We will discuss about it a little later. So what are the key takeaways now coming to the medical and dental education? We just talked about how AI has evolved, what are the different concepts, how it has impacted, very briefly, the healthcare, especially medical sciences, and then dental sciences, what is happening now. But now we are coming to the education and how we can redefine our dental education or a medical education by boosting curriculum with AI, because I think that is the need today. And of course, continuous training with supervision, what we are traditionally doing, and feedback, which is we are assessing ourselves, is the key to good dental education. But that doesn't mean that AI cannot be incorporated in our traditional education. So what can AI do for dental education? And when we say AI, we also consider it like a digital dental education, because I think it starts from digitalization, starts from digital form, and then only it evolves into AI. So AI has been, I think, already incorporated into intelligent education through simulation, enabling simulation, especially for practical procedures, is quite popular now, I think, even in our country, but more so in a lot of countries abroad, because also I think in Corona times or even otherwise, the contact with patients was much less. So the students were trained on simulators. And the best thing is that when you're using a simulator for education, one can try many times till a skill set is experienced, because otherwise you can only do once in a patient, and there's no getting back from there. So this method of training can be very efficient, inexpensive, very reliable. And also, I think the feedback is very instant, and feedback from the students and from the patient. So there can be a huge improvements in that. So let us see what Dr. Charles Goodacre, I texted him and I asked him, what is your opinion about AI and digital dental education? And he said, the future of dental and medical education needs to include digital technology in all aspects of medical and dental treatment, as it continues to impact both education and practice. As I already said, that we cannot separate a practice from education in medicine and in dentistry. However, we must continue to monitor the new technologies to be sure they at least meet or exceed the precision of our heritage techniques. Now, I think it's a very big and a very potent statement, which says that not every technology or every such thing, fancy thing which is introduced is good. So we really have to watch them and see that they are better than what we are been traditionally doing, the use of technology, but be part of the didactic and technical aspects of medical and dental curriculum. We must become more efficient and effective in presenting material and helping students think and not just memorize. I think using that, we will be making them, learn on their own, rather than just what we've been doing traditionally, memorizing and then trying to recall. While it would be sad to think students can learn everything at home, but there is a place for some material to be. So everything cannot be done digital, and students cannot do everything on their own. But yes, he says that there is some scope for some material to be presented this way. So we must continue to take risk and experiment. So I think that says it all. And so based on that, today we have the new gen dental students, and I'm sure it's happening in our country also, which is learning not theoretical but simulated, and through the virtual world. Let's see how a simulator can help a student learn, especially the practical aspect.
Simulator, where we're able to simulate a patient and the entire dental station, the entire operating environment. We simulate the tooth of the patient. So we use CT scans of real teeth and generate 3D models. And so within this environment that we use a head-mounted display called an HTC Vive. I think many people have seen these. That gives the user a 3D stereoscopic view of the patient and the room. And we use haptic devices, one that controls the dental drill and one that controls the mirror. And as the dental student is drilling, they can actually feel what it feels like to drill the tooth. And as they drill it, of course, the tooth is made of different kinds of material. You have the enamel, which is very hard. You have the dentine, which is softer, and then the pulp inside. And we even simulate the density of the tissue so it feels correct. So a student can carry out the procedure with this simulator.
Okay, so let's cut it short and move on. So what are the current store in dental education? First is haptic technology, as we just saw this video. We are teaching with touch and movement. Haptics is a study of human touch and interaction with the external environment via touch, and models enabling the sense of cutting enamel. I think this is becoming mainstay today, and not only in dentistry. I think in a lot of medical schools in their surgical training and many of other areas, they're using haptic technology. So the result shows that haptic devices can be developed to stimulate traditionally taught skills, which we otherwise teach on patients. So, but of course, the cost and lack of research in terms of effectiveness, as I said, that every new technology not necessarily is superior than other something which is very traditional. But it looks like that haptics technology is going to be mainstay in teaching students their psychomotor skills. Then another one is a immersive environment where simulation can be taken to a next level, because you're doing simulation, but the environment has to be environment which has a so that get immersed when combined with the capability of a 3D environment. A 3D environment haptic, I think that makes it much more potent.
Mahesh can't hear you. Everybody can hear?
No, ma'am.
No, ma'am.
No, ma'am.
No, ma'am.
I think he's logged out. Logged out, I think. Mahesh? Mahesh, we can't hear you. Mahesh?
Hello? Okay,
We can see you, sir.
Oh, no. I think it has gone to... Can you...
Slide is visible, sir, but...
First slide.
I know. I'll have to Let me see. I will start. Can you hear me now?
Yeah,
Yes,
we can.
sir.
Yeah, you scroll it down.
Yes, sir.
Scroll it down.
Yeah, I
think
know.
it was
I think
last-
there's some internet issue.
Yeah,
There's
I
some
think-
internet issue.
Yeah.
I know. I'm sorry. I'm sorry.
No problem.
Okay.
43 or 44 somewhere, sir.
47, sir.
47, sir.
Okay. No problem. No problem. 45, 46, 47. Okay.
Yeah.
Okay. So Roberts, I think I just talked about Robert. I think let us not repeat this in 1 minute. So, and there are robots today, like this Morgui robot, which is using all the senses, 5 senses: vision, audio, ultrasound, radar, and infrared. So, I think in coming times, the robots will be used not only just for activities, but also to visualize oral cavity and human body, combining imaging modalities, so that it can give you the X-ray vision of the patient. And another good thing which is happening is semantic web. Semantic web is actually the data which is connected worldwide. We use www World Wide Web, where semantic, the data, pertaining to different patients and different treatment modalities is structured. It is categorized, and it is in a web, so that computers, if you have a link, computers can access that data, and it can utilize that. So that what happens that everybody can access the information from the web, and the situation can be very useful for anybody which is located in different parts of the world. So that's another thing which is going to impact the dental training or dental technology or dental care. And then connected campuses. Today, I think if we have our IT infrastructure, like suppose all the dental colleges in the country, they are connected through a set of IT infrastructure, then what happened? I think we can share resources, e-learning resources. This is already happening in education. Like I'm sure you must have heard of MOOCs and portals, Swayam portal, e-Pathshala, where all the resources, massive online, open online courses, MOOC, those are prepared by different universities, different schools, and it is embedded in the platform, and then it is accessed by different institutions. So connected campuses. And that in our new education policy, the government is saying that foreign universities, they can set up campuses in India, and Indian universities can set up campuses abroad. So somewhere, using this, what we can do, that the problem of shortage of highly trained academic staff and knowledge, information, it can be shared, and it can generate a lot of learning material and a lot of hard-pressed dental resources which are not available, which may not be available, especially to some institution, that can be utilized, and there can be optimum use of resources and teachers through this. So what are the challenges now? What can AI do in education? But there are challenges. It's very easy to say, it looks very evocative and very exciting, but that Rome is not built in a day. What is the first challenge is that our traditional curriculum has been a memorization based. So what we are doing, we are imbibing information and recalling it, utilizing it when the patient comes to us. So what needs to be done? I think efforts need to be redirected in acquiring knowledge management, like a clinical decision support system, where you are acquiring the information and using it, leveraging AI, and helping the patient diagnose and treating the patient. So that's the first challenge, and this is the answer to that. The second one is we don't have any computer basic training to students and even teachers. I think they're naive, because if we want AI to help us, help us move forward. I think somewhere we need this. While AI has revolutionized the technical medicine, it has brought in its wake of a lot of practical, conceptual, and other issues. So the AI age in medicine promises to reduce complex patient experiences to linear problem-solving intervention, promising solutionism. We know that AI can help us solve a lot of complex issues, but we need to be prepared for that. So we need our students, our teachers to be computer savvy. So patient care has been holistic and needs a warm touch, embracing cold technology and warm hand patient care needs to walk hand in hand. So we need the human touch also. We need which is warm, and we need which is cold. It can be blend of both. Then only we can move forward. The third challenge is information overload. Don't you think that? Hello. Can you hear me?
Yes.
Can you hear me?
Yes, sir. Yes, sir.
I think my internet is showing me that it is unstable. So
we can hear you.
Hello.
We can hear you clearly.
Okay.
If we can't, I will let you know.
Okay. So another challenge is that there's so much of information overload. Don't you think that our students, they have to study so much information, and how is possible for him or her to retain it and recall it? So AI can really elevate all this, and it can communicate very compassionately with patients, and when all that happens, when you have too much of information over, too much of things on your head, and you have to do on your own, I think it brings about a professional burnout. So what AI can help us, that a lot of all these complex things can be taken up by AI, and the doctors or the students, they can be left to do something which are more actionable, and which can bring about more personalized results, rather than bringing about professional burnout. So that's another third challenge which we are facing at the moment. So technology is a tool, and medicine is an interpersonal bond. The fourth challenge is basic and clinical sciences are stressed more. And if you look at it in our traditional education, everything is in silos. Nothing is connected. We study anatomy, then we study physiology, we study biochemistry. It's not connected, in silos. So, the promise of AI is in more of a personalizing teaching. And, what is today, we are doing this program because we know that the need is case-based, problem-based, and a complex scenario-based learning. So because patients don't have a singular problem, they come with a lot of conditions together. So I think a shift from hands-on clinical work to a technology-enhanced scenario, I think that's much more better, and that only can be done through AI. Another challenge is that engagement of the students. The lectures have been didactic and very passive, isn't it? That's why we are doing this program, how we can make it more interactive. And so our traditional teaching has been very less effective as a teaching tool. So AI, as I said, can be both. It can be replacement also. It can be replacement of a teacher. That means not totally replace it, but it can supplement also. A lot of things student can do on his own, and a lot of things it can supplement to the teacher. It can supplement the teacher to, and the outcome of AI experiment could affect the future of education on a global scale. So chatbots, see what happened normally. Students are not very forthcoming when it is asking questions in the class. Very hesitant. They will not, even if they have a doubt, they will not come up. So, but in AI, there are options of chatbots, and where they can have a natural dialogue either with audio or through a text, and they have a capacity to perform complex tasks. So all that can be done. These challenges which is there in a traditional education. Doctor-patient relationship. a theoretical concept. We know ideally a doctor-patient relation should be good, but what happens? When we come across a situation where meeting a doctor who is the least bothered to pay attention, and it happens in many of the situations when we are overloaded with so many patients, especially in the government sector. I think when a lot of these calls are done by AI, I think we can give more emphasis to empathy, compassion, the ability to listen, pay attention, and communicate with our patients, which normally doesn't happen because we are bogged down with so many other situations. So we can, AI can help us provide a better care at a lower cost, and it has a potential to revolutionize the healthcare. The next challenge is the new concept in research and data analysis. I think data is a goal today, and we generate a lot of data, but we don't utilize that data. And bigger the data, bigger the confusion, because we are, as we are expanding, we are generating a lot of data. So what AI can do, it can precise the data, use the data in a clinical research, drug discovery, make the medicine more precision, for a targeted therapy, improve the safety of the trials or the clinical trials. So a lot of things can be done through AI, which we are facing at the moment in education. And also, I think the biggest challenge is the reluctance of the professional to change, because we are very traditional, and we want to continue doing that. So I think it's a big task for all the higher educations, universities, the providers, and assessors of medical and dental education to challenge and promote change. Because future reality is AI-enabled educators replacing no AI-enabled educator. Somebody asked whether AI will replace doctors, physicians, or dentists. Eventually, everything will be done by AI. It is said that no, AI will not replace professionals, but AI will certainly replace professionals who don't move with times and who do not incorporate AI, in their practices. So the moral of the story is that AI cannot replace physicians or doctors, but it will certainly look for professionals who have to incorporate digital technologies, AI-based technologies, and computer-based technologies in their day-to-day practices, or for teachers in their education. So what makes a strong case for AI? Why we are pitching for AI? One is that certainly it helps us improve diagnostics, especially when it comes to imaging, radiology. It gives us digital health data, which we need, I think, today. That is the need of the hour. It can consolidate data from various sources, which we are not able to do physically. It can help us research and discovery through experiments, can take over routine tasks. A lot of mundane tasks, which is we do, can be very easily done by AI. It can empower the patients to self-monitor. A lot of things can be done. It's so empowering patients, empowering doctors, empowering community. It can perform tasks instantaneously, almost in no time. It can give us logical and a very feasible decisions. The clinical decision support system will tell you what is practical, what can happen, what is possible. Procedures can be standardized, which is not, because every patient is different. You cannot standardize teaching. Accuracy in diagnosis, cost may be decreased, cost containment, and it can facilitate lifelong health record. Another one is that it is available 24/7, and it can increase human capacity, because we can share a lot of resources and bolster emotional well-being of the patients who are suffering. And it can predict and forecast a lot of problems, in future going to happen. And we can prepare ourselves, forecasting a lot of things, which otherwise also through hereditary disease, or for which we got to prepare now. It can do that, and it can truly improve management of healthcare facilities by use of predictive analysis. Now, this was reported by Falk Scavendike, who is a focus group chief in a international standard organization who's working on AI, and he's also the chair of the working group of AI in FDI. In FDI, and I've been working with him, and that's how I got interested in all this. So, but everything is not good. Everything is not. There are limitations. There are disadvantages. It is very easy to say, but things are expensive. Mechanism is very complex. It's a costly. It needs money. It needs training. Data is often there can be a data snooping by, because we are using the same data for training also and testing. When you're using the same data twice, it is likely to be less predictive, and outcome of AI in dentistry are not really readily applicable. If you are using AI in dental treatments, sometimes you cannot measure it. You cannot readily, you cannot apply it, and you cannot measure it. So that's another limitation of AI in dentistry. So, and also there is a thought that AI neglects patient-doctor relationship, which is a fundamental credit, because if everything will be treated by the machine, or predominantly it is treated by machine. So, there's a statement that, is AI taking us away from human touch? Is it taking us away from a patient-doctor relationship? Of course, that will not happen. But this is one of the doubts, one of the limitation, or one of the thought process in many minds. It fails to improvise in emergencies. It's very streamlined. It cannot improvise. And AI databases are based on target groups. So it is only for a certain group, and it sometimes lacks certain sections of the society. And the software, all those things have to be frequently upgraded. It needs enormous time if there is any breakdown, or it requires any recovery. And we don't have any experienced manpower, programmers. Very easy to say, but we need human resource which is experienced, which is trained, and that is a big challenge. So, what are the current concerns? Besides that, there are a lot of other current concerns, especially if we want to incorporate AI in our dental curriculums today, because we don't have no uniform standard in dental education for digital tool. We have Dental Council of India is coming out with the regulations from time to time, but I don't think it has any standards for a digital education. So we need to come up with new standards which have to be defined, and it has to be uniform. It has to be applied all over. So which phase of dental curriculum should carry digital technology? Which part? In prosthodontic, whether are we going to teach complete denture? Are we going to teach crown and bridge digitally, or are we going to teach it in a traditional manner? So there are many concerns. Which component or traditional component we should omit, and which extent of conventional workflow will be taught? So what digital content should be taught in which discipline? So if it is orthodontic, which part of which content of the curriculum should be digital? Industry collaborations are win-win, but they have commercial interest. So for us, whenever an industry comes up with some new AI application or new AI gadget, we want to apply it, but that's industry linkages. But they have a commercial interest, so we really don't know that how beneficial or how good that technology is. So that's another challenge. And dental schools in future shall be ranked according to digital infra and innovation, isn't it? Today, NIRF ranking or NAC accreditation or NABH accreditation, I think in times to come, I think we also need to measure these institutions, because these are contemporary technologies, and we want that these have to be incorporated in dental education system. Then only it can reach all over. And so if it has to reach all over, I think the institution have to be measured for digital infrastructure and innovation. And besides that, there are other challenges. If you want to come up with standardization, regulation, and certification of AI, ethics, autonomy, because patient has to decide what he wants which is one of the ethical principles: fair play, transparency, reliability, security of the data. Because the data, a lot of these companies, they use data, they share data. So all those protection of data privacy. So some of these other challenges which is there. So do AI application respect social values and laws? Because what is if AI is being used in India and a similar AI is being used in other countries which are connected with AI,
Mahesh, we can't hear you.
Anything new which is helping us streamline the processes or helping us Hello?
Now it's not very clear.
Okay.
I think the internet is unstable.
Now it's fine, sir.
Now?
Now it's okay.
Yeah, okay. So just a couple more slides now. I think we are end of it. So what is, I try to gather some information from different educators in different parts of the world. And, I asked Dr. Shankar, what do you think about AI and digital dentistry and future of dentistry? So he says AI, artificial techniques is going to be there. Future dentistry shall certainly focus on it. And because especially in prosthodontics, all our 3D jaw movement, simulation, functional restoration, all that will be used. AI will be used there. Expansion with digital workflow into scale analysis with the aid of guided prep techniques, robotic assisted tooth preps from a predetermined design, remote teaching techniques, utilize simulation, that if there is a simulator in US, I think can be used to train from India. So that is labs that can interface with universities abroad, creation of satellite off-campuses training program to facilitate access to remote area. So all these things. So AI can certainly increase the reach and also can increase the quality of education. But and then similarly, I asked Professor Marcus Blatz, who's looking after digital innovation and professional development at the Penn School Dental Medicine, University of Pennsylvania in Philadelphia, who's also part of the AI working group. And what I asked him, what do you think? He said, yes, it can identify preventive tools which can use that data from humanistic standpoint. It will enhance access to care. We can learn from other industries, and let's see what he said.
I mean, right now, when we provide, I think, an assessment of what's available, it's probably going to be outdated in a very short period of time. But I think that's what we need to do and clarify for the practitioners and for our members where we are and then where we could be in the future. The research aspect and combining the general health data, that is the big topic and one of the most important ones to synthesize the information from both the dental and the general healthcare, and then identify tools that can help with prevention much better than we have done before, because we have much better data available and much greater data to help identify that. And I think it's one of the most important topics for the general health population, and also how we can provide access to care from a humanistic standpoint as well. So I think we can learn from some of other industry also how to implement it better. That's always a good thing. So
okay, and then Dr. Falks Kevintke, as I said, that he is the one who is chairing AI at International Standard Organization, and what he had to say.
And it's the same with AI. I think a lot of the dentists, as you said initially, they just heard buzzwords and they are either excited or afraid, but neither of these two groups understands anything about it. And I think it's a little bit our task to, would be one of FDI's tasks to really also educate them a little bit. This will take time, of course, but it would be also an important step to increase quality.
So, and then, of course, I was also part of it. And I had my own perspective by Indian.
Our dental profession is very familiar with the term AI,
And not only that, I think everyone is using this term, but we need to consolidate that what is being done currently and what could be done, what could be the possible areas, because we have industry representation here. And so it's not just, digging out what is being done, but also give a direction, certain areas, what could be done. So I feel that what could be the role of AI currently and in future for the primary care, for utilizing it for the universal health coverage, and also how we can utilize AI to integrate oral health into a general health. And of course, these are the areas, but the ways and the pathways and roadmap could be very diverse. So these were, all some of the discussion we had during FDI AI working group meeting. And because we were not just focusing on a dental care, dental education, we were also thinking that how AI can be used to integrate oral health into general health, because that is what FDI is working on, and also how AI can be used for a universal health coverage, because that is where we want to increase the equity, accessibility of the care, and expand the dental care reach to the masses, even to the remotest part of the country, here. So, so it's not just, let's not just restrict AI to the care, what is happening today, and AI for a dental education, but also expand it further. And its role is humongous and expand. But yes, there are a lot of challenges, a lot of limitation. And as Falk said, that will not happen overnight. It will take a while, and there are many challenges which need to be faced. But eventually, I think there is a great future. So, rise of AI in India.
The world's population has no access to reliable, affordable healthcare. We believe that machine learning and artificial intelligence will make healthcare affordable and accessible to the world's population.
We've set up an entire analytics vertical in-house on Microsoft SQL and Power BI to derive optimum business and clinical value. We started regularly analyzing multiple data points around lab tests in one of our units, and within a month, we saw a 60% increase in efficiency across the processes, and close to 95% of the lab tests were turned around in less than 2 hours.
We can accurately forecast under or overstaffing in real time. We can even predict patient volumes. Our AI team has developed a product which can differentiate between the normal and abnormal X-rays. My goal is to make sure that everyone on this planet has access to high-tech healthcare with dignity.
So, what are the India's top AI priorities now? When we are expanding it from dentistry to medicine to healthcare, I think as for Niti Aayog, which is a planning body, which was earlier was a planning commission, it has 5 priorities: healthcare, where India wants to increase access and affordability of healthcare; agriculture, education, smart cities, smart mobility, and transport. So these are 5 areas, and all these areas are going to be, made better using AI technology. So this is AI priority. So healthcare is part of that, And let's see what CEO of Niti Aayog Planning Commission, Mr. Amitabh Kant, says that India today is well positioned to become a global leader in artificial intelligence, and there's a need to adopt it across all sectors. India is now a data-rich country and must become a more data-intelligent nation. So we have a data, but we need to structure the data, utilize the data, intelligently, our computing infrastructure has to catch up. So that is really that we need to create systems, and we need to create especially hardware, software infrastructure to reach all over. And also, when it comes to healthcare, I think we all know that we have a PMJ, Prime Minister PMJ, that health Yojana, and which is part of digital mission, National Health Digital Mission. And as part of that, there'll be health locker, there'll be electronic health record. I think by 2020, I think they are planning that there'll be a EHR, there'll be electronic health ID. Every person will have an electronic health ID, and all the data will be electronic, and it will be there'll be repository, a health locker where it will be accessed there. So I think we expect that a lot of this data can be utilized by AI for planning, for from making schemes, government policies. And I'm sure it will also include education, health education, medical education, dental education. And also coverage and claim platform is also envisaged for health protection schemes, national health analytics platform where all the information will be analyzed, and a unique digital health ID for each citizen. I think it was in September last year, I think our Prime Minister had released that every person will have a digital health ID. So it can really, AI can really leverage healthcare in India. AI could optimize existing resources, because we know that we have a lot of limitations, and AI, not only that, can optimize, it can also monitor and assess the population health. What is the target public health intervention to better effect, and especially oral care, oral health care. I think it needs to expand. So can we look forward to AI and digital health mission as part of that to enable that, doing that, it also enables frontline health workers, including community health workers, with AI-powered mobile phone taps. I think we already know that Anganwadi workers and all these frontline workers, they're using mHealth, and that will certainly in times to come, it will change the scenario as far as application of digital solutions are concerned. So India's strength for AI, because we have a very high level of mobile health phone penetration, and I think that a huge development as far as cloud computing is concerned. I think things are, there's a substantial amount of investment in digitizing the health information. mHealth is getting very popular. So all these are good signs, good points, which can, where we can utilize AI for future. So as futurists, I think we need to stay updated with the latest innovation and explore the growing possibilities in healthcare. Because what is our aim? Our aim is that even as an educator, we are committed to provide the best health, best treatment, best dental care at the lower cost, and AI has the potential to revolutionize healthcare. So let me thank you all, and especially acknowledge Dr. Suhasini Nagda for giving me this opportunity to speak here. Thank you very much.
Thank you, Mahesh, for an exhaustive talk on AI, and it has been an eye-opener for all of us. And I'm sure that the participants look forward to working in this field more and more with the partners, with the industry partners and the research partners. And I want to tell you one thing, that when the 50th Golden Jubilee Conference, which is in New Delhi, of Mahesh Verma is the chairperson, and we are looking forward to having a convocation ceremony in New Delhi. Mahesh, I had already spoken to you, so we need to talk about it a little more in detail, because we want to have a proper graduation ceremony, and so that
yes, Suha, please, email me so that we can schedule it properly, because we have very limited time, and we want to have a lot of activities. So yes, I have promised you that you want to have a convocation. Can we do it a day before? On the day of the pre-conference courses on 10th, because it will be much more quieter and much more better.
But I don't mind that. I don't mind that.
So there'll be a lot of people that day, because we may have a 200, 300, 400 people even on that day. So we can do it very nicely on 11th, rather than doing on 10th, rather than doing on 11th, 12th, and 13th, because 13th is the last day. 11th, 12th will be really busy.
No, 11th or 12th in the
11th
evening.
will be 11th will be inauguration, and 12th will be convocation and award ceremony. So there will not be enough time. If you want to really do it nicely, let us do it on 10th evening.
Okay, I will email you tomorrow and we'll discuss about it. And I want them to be in robes and all, so that it is done in style. Yeah, all of you. Yeah. So that is the reason, Mahesh. Mahesh, I'll talk about it because we wanted to start one symposium on education, which I did this time with the other conference. Okay. We had a slot for education. I'll email you everything, and just speak about the conference, the dates to these people, so we immediately register, right?
Yeah. Okay. I am sure all of you know that 50th IPS conference is going to be held in Delhi from 11th to 13th November this year. 10th will be pre-conference courses, and this is a golden jubilee. 50th is more of a celebration also, and this is the opportunity to, because after almost after 2 years we have not had a big gathering, so expecting a big gathering. I want to just share with you that we may have Sri Ravi Shankar addressing us digitally, and I'm also trying to connect Gordon Christensen speaking to us during the conference, and then we will have, of course, a couple of other foreign speakers. But this time also, I also want that let us recognize people who have contributed to our profession, who have nurtured our profession over the years. They could be technician, they could be general dentists, they could be, it is not that they have to be faculty. So I wish that if you want to, if you have somebody in your mind, please send us the nominations, send us the suggestions, and we would like to acknowledge their presence, how they have in the last 50 years, how they have nurtured the profession, not only in India, but those who have brought glory to the profession abroad also. These are some of the points. This Sunday we are having a meeting. This coming Sunday we are having a meeting. Conference Secretary Dr. Gandhi, Udavir Gandhi, is coming from Calcutta, and some of our close group people, about 15 of us, are meeting on site and just trying to take a stock how to do it. We still only have about 600 registrations, so we are looking for much more, because we don't want to have too many people, but certainly I'm looking for a crowd of about 2,000 or 2,500, because hotel can only accommodate that much. So please, without a delay, those of you who have not registered, please come forward and register for the conference. Registration can be done online through our website. Thank you.
Thank you so much, Mahesh. So we'll not take much time for questions or anything, because it's already 9 o'clock. So thank you, Mahesh, and we look forward to meet you again, once again, maybe in April or May.
Yeah. Sure.
Probably May. Yeah.
Thank you.
Yeah, thank you.
Thank you so much, sir.
Thank you, sir.
Thank you so much, sir.
Thank you so much.
Thank you, sir. It was really mind-blowing, sir.
Thank you.
Excellent lectures.
Thank you. Kya haal hai, Rupinder? All well?
Thank you. Yes, sir. We all are registered. You asked, sir. Half of them are registered.
Yes, sir. Yes, sir. Yes, sir. We all are registered.
More than half, sir. More than half.
Thank you.
Thank you, sir.
Thank you so much. Thank you. All the best.
Thank you, sir. Good night.
Good night, sir.
Good night, sir.
Thank you, ma'am.
Thank you, ma'am.
Thank you so much. Good
Thank
night.
you, ma'am.
Thank you,
Good night,
ma'am. Good night, ma'am.
Good night, ma'am.
On Friday, we are having a very unique this thing on difficult conversations. We call it as crucial conversations. So please log in on time. and we will be taking now group wise meeting. It is called as learning circle, wherein we are more closer to each other. I will be there and I'll try to rope in your mentors, but if they are not there, and please feel free to send me personally on the email your topics and your education protocol, because any which ways I'm going to be signing on all the educational research. We cannot allow any research to go which is not refereed properly. So we are 2 or 3 of us who are going to be there everywhere, like head of the department signs that type. So we are responsible, and I want to the quality where we can at least publish a few of them. So please see that you are there. Yeah, encourage your group members to be attending, to be coming on time. I see some of them, the person Samik marks absent, and after 15 minutes I saw somebody, 20 minutes, half an hour, 45 minutes I saw. I called him up and told him, "Arey, mark kar de usko." Bota, "Madam, wo dar waqt hi aise hi aata hai." That's not good, you know. So please see that because certification is not going to be a cakewalk unless you are regular, unless there are already 1 or 2 people out. So please don't do that. I don't want to be harsh. I want to be very friendly environment for you. We have created it so far for you. Thank you so much. Good night. And have
Thank you, ma'am. Good night, ma'am.
Good night,
ma'am. Good night, everyone.
Lalit, you are so cold.
No, sir. No, ma'am. It's cold over here, ma'am.